Good morning, everyone. Can you hear me okay? Is this loud enough? I don't want to be too loud. So we've got some lights. Wow, we lowered the lights. So it might be a little dark in here, but hopefully for some of you, you might find that comfortable. We're going to get started. Shirley Kessel. I'm the executive director of Miles for Migraine. And along with our co-host this morning, you will get to hear from Joanna Curran in just a few minutes. And she is the founder of For the Love of Ryan. So I want to welcome you here today. It's so wonderful that you've decided to take the time for yourself to come here today. I believe that you're really going to hopefully gain some insights. I just also want to give a shout out. We've got people on Zoom that are also watching this virtually and will be participating along with all of you. You can't see them, but they can see us. So give them a wave. And I just also want to thank our sponsors this morning. So without their sponsorship from Lundbeck and Pfizer, they are actually, Lundbeck is here in the room today with some patient resources. And so I really recommend that you go over there during the break and also at lunch and learn more about living with migraine, because there's so much more than dealing with symptoms. As I'm sure all of you know, migraine is a very complicated disease. It's also very isolating. It's can be a really lonely disease to have to face on your own as you're lying in a dark room for so much of your life and feeling like there's no hope. And if you are one of those people, I really highly recommend that just say hi to someone else in the room today that you've never met, because I guarantee they're just as nervous and fearful as you are. But once you start to have a conversation with someone, you'd be really amazed how many other people here are just like all of us. I have chronic migraine. I've lived with it from chronic to episodic my whole life. And so please even come say hi to me. I want to get the opportunity to meet all of you. And has anybody ever been to a Miles for Migraine walk run here in Atlanta? Okay, you have. Okay, we also offer a walk run that will be coming back again in probably April. We also offer Miles for Migraine offers other programs besides just these education events. We have a whole host of free recorded education topics from everything that you could possibly need to know about migraine. They're on our YouTube channel. If you go to our website, the speakers that we use are very well respected in this field. And please, take the opportunity. We also have an advocacy training program called Act Now. If you are interested in learning more about how to advocate, even how to tell your elevator pitch, it's really important. That's sometimes something that we do at some of our education events is we really try to teach people living with migraine how to reduce stigma. Because how many times has someone said to you, have you tried? Oh, I get headaches too. Have you tried Tylenol? Okay, so reducing stigma is something, that we all live with and the thinking that migraine is our fault. It's not your fault. Also, we offer a mindfulness program every other Thursday. You can come for everything we do is free, except our races. We got to charge a little money this year because we were not making enough money to sustain our races. But all of our programs and services are free. We also have an online support group. And For the Love of Ryan also has support groups, but they're going to tell you more about that later. So I'm just going to go right into the other topics of business here. Feel free to use the restroom at any time. You don't have to wait for the break. Just take care of yourselves. If you need to, you're not feeling well, go out there and this is a huge place, go find a place to just be quiet by yourself if you need to do that. This is being recorded. If for some reason you're not feeling well again and you just have to leave, then take care of yourself. But we hope you can stick it out for the day. Okay, so without further ado, I am going to read the bio of our first presenter, and that's Dr. Corey. He brings over a decade of experience in neurology and headache medicine to Panda Neurology and the Atlanta Headache Specialists, serving patients in and around Metro Atlanta. Dr. Corey began his professional education at the American University of Beirut in Beirut, Lebanon. He graduated summa cum laude, then completed a combined master's in neuroscience and earned his Doctor of Medicine degree. Following graduation, Dr. Corey relocated to the United States and completed a neurology residency at the University of Oklahoma Health Sciences Center in Oklahoma City. After finishing his residency, Dr. Corey moved to Texas and participated in a fellowship in child neurology at Texas Children's Hospital Baylor College of Medicine in Houston. After completing his fellowship, Dr. Corey returned to Oklahoma and was the residency program director. He then moved to Texas and served as the medical students neurology clerkship director, headache fellowship director, and director of the Comprehensive Headache Institute at Baylor before joining Texas Neurology and serving as the associate director of their Comprehensive Headache Institute in Dallas. There, he focused on clinical research and advanced therapies for the treatment of patients with acute and chronic headaches. Dr. Corey is currently an adjunct clinical professor at Morehouse School of Medicine. And he also is board certified and provides neurologic care for adults and children alike. He welcomes anyone seeking comprehensive neurologic care to Panda Neurology and Atlanta Headache Specialist. But before I have you come up, I just realized that Joanna Curran did not come up here yet. Joanna, you want to wait? Okay. All right. Joanna was supposed to introduce me and I kind of screwed that up. So I apologize. Okay, then let's turn it over to Dr. Corey.
And that is the migraine brain. We're going to talk about that right now. She did acknowledge she has chronic migraine, right? So that's what I'm going to talk to you about. So I'm Shawik Corey. I'm at the Southeast Center for Headache, not Atlanta Headache Specialists, but it's all the same. So we're a comprehensive headache center. These are my colleagues over there that will speak after me. And we provide comprehensive headache care for adult and pediatrics. So I'm dually trained in adult and child neurology and then specialized in headache medicine. And we cover all the surrounding states, including Texas. We provide a lot of telemedicine and in-person care in all of these states. So what I want to talk to you about is migraine pathophysiology. I know it sounds like it's a big topic and it's more geared towards like headache specialists, but it's really something that I feel headache patients should really know very well because it helps them understand their disease process. It also is very important for headache caregivers to understand this because it helps them understand the patient they live with, because migraine is not a patient disease, it's a family disease. So do we have any caregivers in the room, or it's all headache patients? Great, I love seeing caregivers because when mom is suffering with migraine, the kids need to understand why. When your spouse is suffering with migraine, you need to understand what's going on. So what is going on with migraine? So let me make sure I understand how this works. Perfect. And then where's the camera for the online people? Is that, okay, perfect. So that I make sure that we're looking in the right direction. I'm really sorry, I'm very myopic. I didn't know how far the screen is going to be, so just give me 1 second because I can see nothing. Now we're talking. So what is migraine, right? We've all heard this where migraine is more than just a headache. We hear this all the time. Migraine is this neurologic disease with a lot of symptoms. But what exactly is going on? So the current understanding of migraine is that there is some kind of neurologic problem happening in the brain that causes us to have a multitude of symptoms. Pain is definitely one of the most common, but pain is not necessary. We have a bunch of patients who have migraine who've never had pain. And the first time you tell them, oh, this is migraine, they look at you like you've got horns or something, because like to them, migraine is headache. And you don't have to have headache to have migraine. These are a minority of patients. Most patients with migraine have headaches, don't misunderstand me, but you don't have to have pain to have migraine. Migraine is this complex of neurologic symptoms that happens because of what's going on with the brain. Why did it take this long to understand migraine? You have to remember that forever, doctors were guys, and migraine patients forever were only women. Why is that? Because male patients with migraine never came forward, because migraine is a female disease. So they would never acknowledge they have migraine. My own father-in-law, to this day, would never acknowledge he has migraine. Like, my husband has migraine, and he acknowledges he has migraine. His dad, who has exactly the same symptoms, no, this is not migraine. I just get these headaches, light bother me, I vomit, I'm nauseous. I treat him with migraine drugs. I'm the migraine specialist in the family, but it's not migraine. So there was always this migraine is a woman's disease, it's weakness, just tough it up, right? That's our society, just tough it up. And people didn't understand it, and we never looked at it. And when the women were suffering with migraine, what did we say? Oh, she's hysteric, she has a hysteria. Anybody knows the origin of the word hysteria? Hysterectomy, what is hysterectomy? Cut out the uterus. Hysterus is uterus. So when the guys, the doctors, didn't know what's going on in a woman, they didn't bother to look into it further, just said, oh, she has a uterus. She has hysteria, she has a uterus. And they left it at that. It's the end of the story. And that's why there was this stigma with migraine that we never looked forward more than that. So the doctors contribute to the stigma, society contributed to the stigma, the patients ended up believing the stigma. And that stigma perpetuated until the 80s, when we finally started understanding the throbbing, and we blamed the throbbing on vascular. And in the 80s, everybody was convinced that migraine is a vascular disease. And what I always say, if it's a vascular disease, why don't the heart disease doctors not treat migraine? It's not a vascular disease, it's a neurologic disease. So then, as our capability to understand things and test things improved, we started noticing that the throbbing of migraine is not in sync with the heartbeat. There's sometimes fraction of a milliseconds difference. Sometimes it's a completely different in sync. So we're like, oh, okay, hold on. It's not in sync. What's going on? So we started looking into this further. By then, the sexism was starting to go away. People were starting to look at the Me Too movement. And we started to be like, okay, hold on. We need to listen to these people. That guys were coming forward to say, we also have migraine. And we started looking into migraine. And we started understanding that, okay, there's something real in there. They're not just making up the symptoms. It's not a matter of toughing it up. There is a neurologic dysfunction. There are other symptoms. And we started looking into what's going on. That's the history of how things kind of evolved. And that's why now we look into migraine with more details, and we study it more. And that's why we finally have migraine drugs. This is the first era of migraine drugs, preventive, right? We've had the triptans, abortive migraine drugs, but this is the first time we have migraine preventive drugs, what we call migraine-specific drugs, and my partners are gonna talk to you about that. And even now, it took forever to get the insurance companies to allow us to use migraine-specific drugs. You had to fail the old drugs, topiramate and amitriptyline and all of these things, which are not migraine drugs, before they would let you use migraine drugs. So we're evolving. Things are changing significantly. There is hope for migraine. So what's going on with migraine? So what we started understanding, we started looking at the migraine brain, and it turns out that the migraine brain is always on edge. The migraine brain lives on edge all the time. So when I'm seeing little Timmy with migraine, I'm trying to make sure Timmy understands. I say, listen, who has migraine in the family, right? Because as Joanna said, it's not your fault you have migraine, it's your parents' fault, because it's genetics. So little Timmy, it's usually mom, because it's usually maternally inherited. It can be paternally inherited, but it's usually maternally inherited. So when mom tells you go tidy up your room, and you don't tidy up your room, and she walks in and she gets upset because you didn't tidy up your room, what happens? That a little bit of getting upset puts her over the edge. Because as you can see in here, it doesn't show on the thing, but everybody has a pain threshold, and the migraine brain, because it lives right there close to the threshold, a little bit of getting upset puts them over the threshold and boom, throws them into a migraine. The non-migraine brain, that on the other hand, which is the non-migraine patient down on the bottom, goes in, the red line is the getting upset, that's the trigger, gets upset because you didn't tidy up your room, brings up the pain, the migraine, the brain activity a little bit up, doesn't get them to the pain threshold at all. So he can yell at you, get upset with you, all of that, doesn't get him to the pain threshold, doesn't give him a migraine. It doesn't matter. He can punish you, he can spank you, whatever. It doesn't give him a migraine, right? And that's the difference between the migraine brain and the non-migraine brain. Any small trigger can put you over the edge. And that's why you live your life constantly. Oh my God, lights are bothersome, noises are bothersome, smells are bothersome. And you live your life always fearful. So what is the biggest comorbidity with migraine? Anxiety. Not because anxiety is the cause of migraine, like a lot of healthcare providers do and say and blame the patient and put the blame on the patient. Because migraine generates anxiety. Because you have to live your life with this hypervigilant brain, and you learn that, oh my God, I cannot go to my son's recital. I cannot go to my girl's soccer game. I cannot go to my girlfriend's wine out night. I cannot do these things because I know it's gonna trigger my migraine. So you isolate yourself. Your friends start not inviting you because like, oh my God, she's gonna say no every time we invite her. They don't understand. Your family start being like, oh, mom cannot do these things, let's leave mom. So you become more and more isolated. It worsens your social functioning, and it's a vicious circle. So what do we need to do? We need to quiet down your brain. We need to bring that black line on top as close as possible to the black line on bottom, so that it doesn't take any small thing to put you over the pain threshold and give you a migraine attack. And what happens the more you get over that line? There's a kindling effect, there's a triggering effect. It's like a fire. The more you kindle that line, the more you go higher. So you may start as a kid very close to the bottom line. And then with every migraine attack, your baseline goes higher and higher and higher and higher. And some patients eventually cross the line all the time. They live above the pain threshold. They live in pain all the time. This is chronic daily headache. On top of their chronic daily headache, they still get migraine attacks. On the other hand, that dad that we're talking about that gets upset, does giving him migraine headache, if I take a baseball bat and I whack him on the head, that's a big enough stimulus to put him over the pain threshold, he gets a headache, right? It takes this much to give the non-migraine brain a headache, while the migraine brain takes nothing to give them a headache. Does that make sense, that concept? So what happens during the migraine attack? What are the phases? Oh, and how did we get to understand that? One of the first things that we noticed is that visual hyperexcitability, visual patterns were very bothersome to migraine patients. One of the earliest tests they used in clinic was taking a pattern like that and moving it in front of the eyes of the patient. The non-migraine patient was like, okay, so what? Doesn't bother me. The migraine patient, that alone was enough to be triggering because the occipital cortex is already on edge. So I'm not gonna move it. I thought about it, but I was like, no, I'm gonna trigger a lot of migraines. So the new definition of migraine, what is migraine? Migraine is a syndrome defined by hypervigilance or hyperexcitability of the nervous system. Okay. Due to underlying disordered neuronal hyperexcitability, due to genetic predisposition, epigenetic factor, and superimposed environmental triggers. So the triggers are not the cause of migraine. It's not because of bright light you have migraine. It's because you're genetically predisposed, and then the bright lights on top of that are triggering your migraine, right? It's not what you're doing that's causing your migraine. The environment triggers your migraine on top of that. And what happens? You start thinking that it's all of these things that are the cause of the migraine, and they're not. They're because you're genetically predisposed. One of the common things we see, the migraine patient comes in and they say, oh my God, I've got 6 concussions this year. Very common scenario. I was walking in the kitchen, I banged my head against the cabinet, I got a concussion. Because I had a bad migraine, I got brain fog, I got all of these symptoms of a concussion. True, they're not lying. It's not because they got a concussion with every minor thing, because every minor thing is exaggerated in their brain because their brain is up here already. The non-migraine brain is down here. I bang my head against the kitchen cabinet all the time, I don't get a concussion, right? You need, the non-migraine brain need to get into a car wreck with a huge head impact to get the concussion. The migraine brain any small thing gives them all the symptoms of a concussion. And they come in with 6 concussions per year and sinus infections 12 times a year. Not sinus infections, it's migraine. The nerve of migraine is the trigeminal nerve, which is in the sinuses. So bad migraine can trigger your sinuses. So you get sinus pressure and you get congested and you get the pain in the sinuses, exactly like sinusitis. It feels exactly the same. And allergies trigger your migraine. And any small thing triggers your migraine because your brain is living up here. So it's a different way of looking at it. So instead of always looking at this is the cause, it's actually the migraine that's causing all of that. And that feeds back into the migraine. So it's a little bit of a different change in how we're looking at things. And now in migraine world, we're moving away from the idea of triggers. Now we're starting to understand that migraine is not an attack disease. Migraine is a chronic disease where you're constantly in a disease that has attacks on top of it. So it's not triggers causing an attack, trigger causing an attack, and in between you're fine. You're not fine in between. You're constantly in a disease state. And our job is to quiet down that brain, to lower your risk of these attacks and lower your disease state, manage your disease state. And if your doctor is not doing that, we're not doing a good job. And we see that all the time. These migraine patients who start out in the clinic where every small thing is a trigger. And oh my God, I went here and I got a trigger, and went here, I got triggered. When they're doing better, these things stop being a trigger. How come all of a sudden your triggers change? They didn't change. Your brain is not here anymore. Your brain is here. And it doesn't take these tiny triggers to trigger you anymore. Now your brain can handle these small things. And these small things are not triggers anymore because your brain is not hyper anymore. Oh, sorry. Let me finish up reading the second sentence because this is very important. This leads to a multi-system dysfunction with symptoms highly variable in between patients, pain being by far one of the most common symptoms, though not a necessary symptom for diagnosis. It leads to a multi-system dysfunction, and that's key. Migraine is not only headache. Migraine causes head pain, yes, we see that. All the phobias, light, noise, smells, movement, right? When a mom has migraine and the kid comes and sits on the bed and that movement is like, oh my God, I'm gonna kill you, get off the bed, right? That movement is very bothersome. So movement is bothersome. Heat, it's like, give me the fan. I can't take it. Mom, it's not that hot. Give me the fan. Like heat, like temperatures becomes a trigger. So all the phobias, all the GI symptoms. Migraine causes gastroparesis. Migraine causes constipation. Migraine causes irritable bowel syndromes. So you present with a list of diagnoses that is as if I have 10 diseases and you look like a hypochondriac and you go to the ER, it's like, oh my God, it's this patient again. While in reality, all of these things are one disease. It's your migraine. But they don't understand it. They're not headache doctors. And they look at you with this list of 15, 20 diseases listed on your chart because you see the GI doctor and he gives you 2 diagnoses, and you see the rheumatologist and she gives you 3 diseases, and you see the endocrinologist and they give you 5 diseases, and you see your PCP and they give you 10 diseases, and you give you this, and they never fall off, right? Now with EHR, any diseases that anybody adds into your EHR stays forever on there if somebody doesn't clean them up. So you show up to the ER, you have 25 diseases now, laundry list on the thing, which are all migraine related, but they don't know. And they look at you, it's like, oh my God, look at all the things she has or he has. How are we gonna treat this? What do you want? Let me give her your pain medicine and get you out of here. And people start thinking that you're a drug seeker and you're like, no, don't give me this. They don't work. That's not what I want, but they don't listen. Do you know how many times I send a patient to the ER to tell them, give them drug X, that's the only thing that works for them. And I get called by the ER to say, how stupid are you? How are you not seeing this in Munchausen? I'm like, you met the patient 2 minutes ago. You already diagnosed Munchausen. I know the patient for 5 years. I'm the stupid person? Like, what are you thinking? So there is a stigma, even in the healthcare environment. I understand that fully. And we need to work on continuously educating socially educating people and in the healthcare system educating people. So don't give up, things are improving. That's the important part. And I don't know what's going on here. I didn't do that. I cannot change slides. I cannot change from one presentation to the other. So it's not me. And nothing is moving now. Can you give me back control by any chance? Okay, we're back. So what other things fall under migraine that get called different diseases? From infancy, migraineurs get infantile colic, which we never understood. And these babies cry and cry and cry, and parents are like fed up with them. And now we're understanding this is on the migraine spectrum. They have a hypervigilant nervous system. So any small thing can trigger them. Now, this is not 100% confirmed because there's no way to ask them, but we're starting to understand that this is on the migraine spectrum. Cyclical vomiting syndrome, that's well established as a migraine diagnosis. Abdominal migraine and IBS, this is under migraine. But forever the teaching was, it's the funniest thing, that migraine can cause pain here and here. But it cannot be a little bit higher and it cannot be a little bit lower. Like, that's the stupidest thing. The nervous system is one continuum. The same way it can cause pain here and here. It can be a little bit higher and can be epigastric. It can be a little bit higher and can be chest pain. It can be a little bit lower and can be pelvic, right? Like, there's nothing that says it can only be here and here. Like, that's stupid. And now we're understanding that, yes, it's true. It can be anywhere along the nervous system. So we know you can have chest migraine, you can have pelvic migraine, you can have migraine anywhere in the body. You can have body migraine, fibromyalgia. It's all along the same spectrum. So we talk about globus in the throat, precordial, chest. The old names are functional dyspepsia or functional chest pain or recurrent non-cardiac chest pain, pelvic migraine, proctalgia fugax, rectal migraine, basically, fibromyalgia, vertigo. One entity that is well established that's a migraine variant in kids is benign torticollis. They present and their neck is like, and then it comes back, and then it comes back, and it doesn't happen in adults much. It's really only in kids, this one, and it's young age. I don't know why I'm not moving well. So what are the phases of migraine? You have the interictal phase, the prodrome where your symptoms get exaggerated with or without aura, the migraine attack itself, and then the postdrome as your symptoms are quieting down, you go back to the interictal phase. And this is where the understanding of what I was talking about has changed. Because the old understanding was you're normal, and I don't like the word normal because it presupposes that you're not normal, but we're talking in terms of the brain function. And then you have the attack, and you go back to being able to do everything like you don't have migraine. That's not true. Because interictally, you're still higher. You still have dysfunction interictally. You still have brain fog. You still have fatigue. You still have nausea sometimes. And it's not the same for everybody. I don't want to leave in here thinking that everybody has all these symptoms. Your symptoms will be different than your symptoms will be different than your symptoms. And different people have different combination of symptoms. I'm listing all the possible symptoms. So interictally, patients do not have complete resolution of all the symptoms. And once you treat them, it's amazing when patients come back and say, oh my God, I never realized I could be this good. Because now interictally, I feel I'm back to my old self when I was 10 years old or whatever, 12 or before migraine chronified. And that's what we're shooting for. We're shooting for returning the patient to how they felt and functioned pre-chronification of their migraine. That's our goal nowadays. It's not anymore how many migraine attacks. Yes, it does matter, the migraine attacks, because if you have 15 migraine attacks, there is no way you're going to be able interictally to go back to that level. So lowering the frequency of the migraine attack plays into that. But it's not just lowering the frequency of the migraine attack if interictally I don't return you to a functional level. So if I drop your migraine attacks from 8 to 4, but interictally you stay non-functional or dysfunctional, it's not a goal we're shooting for. We're still changing medicines. We're still trying to get you to a better place until interictally you go back to telling me, you gave me back my life. That's our goal nowadays, which is a great point that we're at because we finally have medicines that can get us to that point. Before now, we didn't have medicines like that, so we couldn't shoot to that goal. And now we finally have that. And migraine is not a static disease. You don't get migraine, it stays the same all the time. Migraine changes over years. I get these calls all the time. But Dr. Khoury, I never had a migraine like that. This is different. I'm like, I don't know what to tell you. Like, there's no answer to that. migraine is not a static disease. That's not to say that if migraine suddenly changes and stays different and continues changing, we're not going to work you up. Because migraine is not going to protect you from other diseases, right? Migraine is not going to protect you from having a brain tumor, for example. So if all of a sudden migraine changes characteristics and continues going downhill, we're going to re-image you. We're going to redo a workup to make sure there's nothing else. Migraine will not protect you from other neurologic diseases, right? We all agree on that. So you can have migraine, and down the road, you can develop something else. So there's no doubt about that. But the fact that you've always had migraine attacks one way, and then occasionally you have a migraine attack that's different, there's nothing to that. Migraine does change over the years. Migraine does change from childhood to puberty, from puberty to adolescence, from adolescence to adulthood. It does do that. Migraine is very hormonally sensitive. So around menopause, it will change. Post-menopause, it can change. So that is not worrisome. A sudden change will need to be reevaluated, but it doesn't mean we're gonna like lose our brain because like, oh my God, you have a different migraine. Oh my God, oh my God. No, migraine can change over the years. The non-headache symptoms can change, but I've never had an aura with my migraine. Whoopie-doo, I don't know what to tell you. We'll work you up, but it doesn't mean anything that you've never had an aura and now you have an aura. Or you always had an aura and now you have one without an aura. Or all your migraines were headache and now you had an attack that is abdominal pain, right? Migraine changes. Migraine is not a static disease. It's an attack in the brain that can spread this way or spread that way or spread this way or spread that way. So it can give you different symptoms from time to time. And evolution from pediatric to adult, as we said. So I'm listing here, and you don't, of course, you're not going to remember that, but the difference in definition even of pediatric migraine from adult migraine. So duration of the headache changes, the quality of the headache changes. So by definition, migraine changes from pediatric to adult. So we know by definition that migraine evolves over the years. And we know that the more frequent your migraines and the longer you've had your migraines, the more the effect on the brain. Remember the kindling effect I was talking about? So we see iron deposition in the brain that is proportional to the frequency of the migraine attack and the number of years. So a 16 years old who has chronic daily headache will have more evidence of brain effect than a 40-year-old who has one migraine attack every 2 months. So it's not the number of years only, it's the number of years times almost, it's not directly that, the frequency of the attacks. A 16-year-old with one migraine a month and a 40-year-old with one migraine a month, the 40-year-old will have more effect on the brain. So we see iron deposits, which indicate energy dysfunction, and we see white matter disease. We see white brain spots, which was a new development back in the early 2000s. We didn't understand that. And I still remember clearly as a resident, I used to undiagnose multiple sclerosis more than I diagnosed multiple sclerosis. Because when this was first starting to being understood, all of these people are like, oh my God, you have MS. Oh my God, you have MS. And they'll come in and they don't have any attacks and they have a strong history of migraine. And you take the history, I'm like, no, it's not MS, it's migraine. But Dr. I'm sorry, it's not MS, it's a migraine. And people who were already on disability for MS did not like me at all because I'm taking away disability. So they never came back and they did not present my notes to that. On the other hand, people who were not on disability loved me because I'm taking away a life sentence and I'm giving them a treatable disease that I can put under control and they can have a completely normal life. So now we understand that, you see, you probably don't know, but all this white should not be there. This is pretty impressive for a migraine. So this is probably a 50-year-old who has very frequent migraine attack. So it progresses to that. And then we wonder why you have brain fog and why you have fatigue and why you have all that. Of course, your brain is under a lot of energy stress. It takes a lot of energy to take care of migraine in your brain. So we need to keep that migraine under control as much as we can. And for you parents, I don't know online how many parents we have who have little kids, you need to treat them ASAP. If you treat early, you can stop that progression. Don't wait until they're having tons of migraines, they're teenagers, and they're difficult to control. You need to treat them now to get them on a good regimen so that they don't progress, so that they don't get to that. And I think that's it for me. I hope it makes sense. Thank you all. I thought we'll do questions separately. That's fine. What?
Okay. I forgot to mention this earlier, but if you have any questions, can you write them down on the 3x5 cards that are on your tables? And Dr. Corey's going to stick around. Thank you very much. And that was an excellent presentation, by the way. It was, I learned something new also, and I've heard a lot of these presentations. And then we'll come around and collect them. And if we don't get to them now, we will get to them during the Q&A time with Dr. Corey. But I'm going to take one question from the chat right now. Question for Dr. Corey. How can we continue to treat our evolving symptoms and pain when our bodies adapt to medications and they become less and less helpful? It's getting to be a real problem for me as the body outpaces available treatments. Maybe that's more of a preventive question, I don't know.
So that's a true statement. Migraine is a dynamic disease, as we said. So sometimes you do something and it kind of works for a while and then it stops working and then you have to change. And that's why even when you're doing good, in people who are adults and have had chronic migraines for years, you don't give up on your headache doctor, unfortunately. It's a Catholic marriage, basically. That's it. We're married for life. Because you may do good for a while, and then it kind of starts losing efficacy, and then you have to do something different. And the nice thing is that that thing that was working, you may be able to come back to it when the new thing loses efficacy. So we keep a running list. If you look at our charts, we keep a running list of what worked and lost efficacy, and we start doing new stuff. And then we go back to the stuff that kind of worked and lost efficacy in the past, because by now they've been out of your system for a while. So there is a logic to how we do things. It's not random. On the other hand, when you capture somebody early on, before they've had this for years, sometimes you're able to reset their brain, and that high hypervigilance goes down and kind of stays down until something major happens. So I always joke with my little girls when they're in my clinic, and I say, you have two options. We either start treating now, especially like if they failed a couple of the pills and we need to go to the shots and they don't want to do the shots. Like, you have two options. You can continue having headaches until you hit menopause, or you let me treat you. What do you choose? And they laugh, and then of course, they accept the shot because they don't want to continue having headaches until menopause, because to them, 50 is like, oh my God, this is like so old when you're 16. The other thing is that there is a lot of people whose brain resets. So there are people, after you've treated them and they've done good for a couple years, you are able to get them off preventive and they stay good. That is dependent on how long their brain was stuck up here. So the longer you've been stuck up here, the less likely you're going to be able to reset. So that's why I say, get treated the earliest possible so that you're not stuck up here for years on years on years on years. Because if you are up here for decades, you're probably going to need decades to reset, decades plus decades. We're not going to get there before the end of life, right? So that's why you're going to be staying with your headache doctor forever. But you need to treat the earliest possible. Can you explain why water decreases migraine? So, sorry? Oh, yes. Can you explain why water decreases migraine? So one of the understandings in how the migraine pathophysiology leads to that hyperexcitability, as we said, I didn't go into the details of that because I was trying to keep it at a level that we can all follow along. The reason why that hyperexcitability happens, there is a genetic predisposition that causes an energy deficiency. So the brain is trying to be in hyperdrive to be able to keep up with the energy demands. And that leads to an overuse, if you want, of water. It's a very simple way of saying that. It's not completely true. So when you don't hydrate enough, it causes your brain to seek even more energy, and you cannot keep up with that. One. Two, the migraine brain likes homeostasis. So anything that throws homeostasis off is a trigger. So oversleeping, undersleeping, overeating, undereating, hydration, because the brain is always wanting to be overhydrated. Any underhydration is a throw off of homeostasis. So anything that throws off homeostasis throws off the energy balance and is a trigger. So think of it, you're here, and these are small triggers. So that's why you cannot oversleep, you cannot undersleep. And my teenagers hate me for that because they want to oversleep on the weekend. I'm like, you cannot really oversleep a lot. I'll give you like maybe 1 or 2 hours, but you cannot really oversleep till 2 p.m. And I don't like that. So water is like that. The migraine brain likes to always be hydrated, and any dehydration throws off the homeostasis and requires excessive energy, and the migraine brain doesn't have the luxury of excessive energy. Okay.
I just want to share with everyone, this is how we clap in the migraine community, so you don't have to hurt your ears. So that was an excellent presentation, Dr. Corey. Thank you very much. And Dr. Corey is going to take more questions later. He's going to stick around. So I'm going to say, if you have any more questions, write them on the 3x5 cards, and you can take them over to that table right there where Joanna and her crew is sitting For the Love of Ryan is sitting there. And we'll make sure that your questions get answered. So our next speaker is going to talk to us about migraine preventative treatments. And this speaker, his name is Simon Bassett, and he is a physician assistant at Panda Neurology and Atlanta headache specialist in Atlanta. He diagnoses and treats patients of all
13.
ages, from infants to children, all the way to senior citizens. Simon regularly sees patients for headache, epilepsy, concussion, ADHD, and other neurologic problems. Simon completed his undergraduate studies at Clarkson University, where he played Division I hockey and was recognized for 4 straight years as part of the All-American All-Academic team. He graduated with a major in biology and minor in psychology. He then moved to Knoxville, Tennessee to complete his studies to become a physician assistant. Prior to starting at Panda Neurology, Simon worked for 3 years in general pediatrics in East Tennessee. He currently lives in Sandy Springs with his wife Cassie and their dog Kita. Kita, is
That's
that right?
amazing. I've had
Hopefully I
it for
said
20
that
years.
right. Okay, good.
Off and on.
When he's not caring for patients at work, Simon loves to play golf and attend sporting events in the metro Atlanta area. Welcome, Simon.
Supplements, and then we did start on a
Ladies, can you please mute yourself? We cannot hear the speakers.
Thank you. Great presentation. Let me just.
Oh, they're the worst. I know. And I get the vestibular one.
Can you please mute
All right.
yourself?
So people online, people here today. It's good to see so many faces. But yes, I'm Simon. I work with Dr. Berenson, Dr. Corey at the Southeast Center for Headaches. Do a lot of headaches all day, every day, of all ages. And today what we're going to do is we're going to talk about prevention. And what I want to do is also talk about lifestyle changes. I know that there was a question about water intake. I'm going to try to touch on that. Also supplementation that we can do to help with headaches. Not everything has to be medication or prescription. I know a lot of patients, sometimes by the time they come to see us, they've seen multiple specialists and they get tired of being passed down a script and try a medication. So that's what we'll talk about today.
I'm like, oh my God.
Let's talk about supportive therapy. So supportive therapy are things we can do. Everybody can do that at home to try to prevent those headaches. And that can be for headaches or migraine headaches. We heard Dr. Corey talking about how our brain lives on the edge, always hyper excitable. And those things can be used to try to bring that threshold down or try to avoid those hyper excitable moment that we have. So good sleep hygiene is the first one. So what does that mean when I talk to my patient about good sleep hygiene? Of course, we want to have restful sleep. We have good night of sleep. But we want to talk about having good routine before bed as well. A lot of patients sometimes will come to me and will say, well, you know what? I really can't fall asleep. I go to bed around like 8 or 9 o'clock, but then I'm on my phone or I'm watching a movie, or if they're younger, or they'll say I'm playing video games until it's like 11 and 12 and I'm just not tired. I'm just not tired. And having a good sleep hygiene is more than having good sleep. It's trying to have a good routine before bed. If we're taking a shower before bed, we try to do it around the same time, so we get to bed at least an hour. If we're looking for something to make us feel a little bit more tired, reading a book would be better than being on our phone, right? We're trying to calm the brain down a little bit. We're trying to slowly kind of teach our brain to say, well, you know what, this is bedtime now. Let's try to get a good night of sleep. We had a good question about water. I'm going to talk a little bit more about water intake here. Good water intake. As a good rule of thumb, what I like to tell my patient is you take your weight in pounds, you divide it by 2. This is how many ounces you should be drinking in a day. And that's easier said than done. I get it. I mean, a lot of patients sometimes come to me and they say, well, you know what? I drink milk, or I drink juice, or I drink Gatorade. I have sodas every now and then. Water is king. Okay, water is the most important fluid that we need. So we want to try to increase our water. And it's really hard to do so when we're not used to drink a lot of water. A lot of patients will come in and say, Simon, I'm just not thirsty. What am I supposed to do? Am I just gonna push water down my throat? No, we start slow and we kind of increase, right? So one of the trick I like to tell my patient is, let's get a 8-ounce cup at home. Okay, and then you wake up in the morning. First thing you do when you wake up, you drink a glass of water. You get breakfast, you drink a glass of water. Lunch, glass of water. Dinner, glass of water. Before bedtime, glass of water. Right then and there, that's 40 ounces of water. And that's just bare minimum. And then once you start using this amount of water, you start being more thirsty. Your brains and your body start craving more water and start realizing, oh my God, I need more water, therefore I'm more thirsty. And then you can start adding on to that mid-morning, mid-afternoon, couple glasses during your meals. And then right then you'll get to 60, 70, 80 ounces. And now you just reach what is the minimum where you should be at. So let's not look at the big mountain to climb. Let's see it at one step at a time, right? Let's slowly increase our water intake to get to that point. Diet. We hear that a lot sometimes at our office and say, what's the best diet that can help with our headaches? And Dr. Corey kind of touched on it a little bit, that migraines can occur. Yes, of course, you can have these headaches, but it can also affect your gut. And you can have this gastroparesis, meaning that it's slowly moving through your gut. And it can cause some symptoms with that. So what we want to do is actually avoid ingredients and diets that are high in fat, right? So if it's high in fat, it's going to slow down your gut a little bit because it has to spend more time there. So low-fat diet is usually what we recommend, right? Lots of grains, fibers, fruits, vegetables. We want to try to have this type of diet to really help reducing the frequency and the severity of our headaches if we can. Avoid caffeine. And every time I talk about caffeine, the first thing I hear is, well, Simon, no, caffeine helps with my headaches. If I don't drink my coffee, I get a headache. Well, yes, that's why we're going to talk about this. For patients that don't have a lot of headaches, or for patients that are not caffeine drinker, yes, having a little bit of caffeine can help with your headaches. For patients that are having daily headaches or drinking daily amount of caffeine, yes, removing the caffeine can make your headaches worse. Okay, so that's why for patients that are drinking a lot of caffeine or drinking their daily coffee, we try to reduce that amount as much as possible. And I'm a coffee drinker. I love my coffee. Patients that I've seen in my office, they see that coffee machine right there in my office. So I understand the need to drink our coffee in the morning. What I like to do is I like to skip a day or two during the week. Okay, so I don't develop this kind of rebound headaches from my caffeine. Best example today. I did not drink coffee and I'm not planning on drinking coffee today. Now, Monday morning when I'm going to get to work, probably going to have a cup of coffee, but that's how we can try to reduce our amount of caffeine. Okay, alcohol, we talked a little bit about this our brain living at a certain level. And then we talked about hydration, right? What alcohol is a diuretic, meaning that we're getting rid of water. So if we're trying to stay hydrated and we drink alcohol on top of that, and then we get dehydrated, we get more headaches. So we try to avoid it as much as possible. I put the headache calendar here. I think it's very important that we touch on that. I know at the practice we have our patient use headache calendars, and this allows us to really understand our headaches. The reason why is that sometimes we'll see patients and they'll say, Simon, you know what, you suggested X, Y, and Z, and you know what, my headaches are way worse than they were. Well, then we start looking at the headache calendars, and actually the number has been divided by 2. There's way less headaches. And sometimes that's a sign that we don't necessarily understand our headaches, so we start focusing on the bad days, right? The days that we were completely disabled. The other way it also occur, I have patients that come in and say, whatever you gave me, this was the best medication ever. I don't have any headaches. And we start looking at the numbers, and then they have twice the amount of headaches. So that means that maybe we're focusing on the good days, right? The days that we were functioning. That doesn't mean that the headaches cannot be treated. And the last part here on this slide, and I know I'm spending a lot of time on this slide, but it's very important. I deal with a lot of patients with concussions. I played sports. I understand the role that sports can have in our life. But it's very important to please, let's wear our protective equipment, right? Helmet, neck guard, mouth guard, but also be able to understand when these injuries occur. If we have somebody that we love or ourselves that are dealing with concussions or had brain injuries, be able to recognize those injuries. Are they, like Dr. Corey said, are they just a migraine that are occurring, or is it truly that I was involved into a car accident and then I need to treat them and make sure that we're on top of that, okay? All right, supplementation. I'm going to go through this slide fairly quickly. Those are things that are over the counter that are very easy to get that can help with headaches. Magnesium can help with more than just headaches, right? A lot of patients will use it with sleep at night, will help them relax at night. It can help them with sometimes even their level of stress, their level of anxiety, right? So it really helps them calm down at night. I put 2 doses on the slide here because sometimes it can give you some GI symptoms. People can say, well, you know what, it gives me some nausea, some stomach pain, some diarrhea. If that's the case, please let's discontinue that. It's a supplementation. It's not meant to make your life worse, right? It's meant to increase your quality of life. So if that's causing any side effects, we stop. Vitamin B2, and as you can see here, the side effect, not the side effects, but the dose is also a supplement that is used as well to try to lower the frequency and the prevention the frequency and the severity of our headaches. Melatonin, we talked about the sleep hygiene earlier. We talked about magnesium that can help with sleep. Melatonin is certainly something that can help with headaches, but also can help with sleep, right? We're trying to get a good night of sleep. I put a pretty big range here on doses, 1 milligrams to 10 milligrams. Well, if you've never used melatonin, let's start with low, right? 1, 2 milligrams. You take it at night, see if it helps you sleep. When you wake up in the morning, are you still drowsy? Are you still tired? If that's the case, well, maybe you're too high on your dose. Maybe we need to reduce the dose. Complement Q10, CoQ10, we see the dose that is recommended there. It's important to know that some of the supplementations are not necessarily FDA approved, right? But with research, when we look on PubMed, when we look at the data that's been done, they are helping with patients with headaches. Butterbur as well can also cause some GI symptoms. Same idea as the magnesium, right? So if it's causing you to have issues, please discontinue that. And I put CBD here. It's becoming more and more popular, and CBD can be used for a lot of things. A lot of patients will use it for their pain, their musculoskeletal pain. There's like cream that you can be used. There's oil, there's tablets, there's chewables. And CBD can also help us kind of relax at night. It can help with the pain. It can help with our sleep. It can help with if we're having tenderness anywhere else. So this can be a good additive. Now, I didn't put a dose on CBD, right? Because it's not FDA approved. There are not really, a lot of dosages that are out there. So if you get to a store that is selling CBD, I would talk to the people that are and try maybe at a lower dose, see how it affects you. If it's giving you side effects, if it's making you feel too drowsy, and then kind of adjust with that dose at that point in time. Some non-medication therapy, right? We talk about a lot as a society. Sometimes we tend to, Dr. Corey touched on it. People have a lot of diagnosis at times from their PCPs and they're being prescribed a lot of medications, but there's a lot of things that are not medication related. And some of the example here. We have the summit group that's here today. I would encourage people to talk to them. They're doing absolutely a great job. But cognitive behavioral therapy, neurofeedback, those are some of the non-medication therapy we can do. Help us understand our headaches, right? If we understand the pain we live with on a daily basis or the migraines we have, it's way easier to treat. Okay, when it's this obscure disease that we have and we don't understand why we're completely disabled when we have these attacks, it's a little bit harder to treat. Okay, I put a couple more here: massage therapy, chiropractor, physical therapy like dry needling, acupuncture. Those are all, patients sometimes will come to me and say, what do you think about doing massage therapy? Go for it. I'm all for it. At the end of the day, I want you to get better. If it's something that truly is helping you, please do so, right? Sometimes these things are going to help with other issues, right? If we're having this really bad like neck pain, this tenderness, that's giving us those migraines. Well, sometimes having massage therapy, chiropractor, physical therapy, evaluate us can be a good first start here. Meditation as well, right? We talked about relaxation. We talked about sleep, being able to calm ourselves down, right? We talked about the brain living on the edge at all time, being able to by ourselves, finding the tools to kind of try to relax ourselves, to reduce our pain level is usually a good first step as well. All right, let's talk about devices, okay? When we talk about management for migraines, there's a lot of medications out there, but now there's a lot of devices that are not medication that we put in our system. And why I put in them there, these are some of them that are available right now. They're all a little bit different. And the Revio, Gammacore, Cephaly, Relivion, some of them are on the arm, some of them are a massage that you give in your neck, some of them are around the head. And they all are, when prescribed, they all come with a certain number of treatment. So I would certainly encourage you guys to talk to either your provider or one of us to see what is best for you. But some of the pros, very limited side effects, right? It's not a medication you put in your system, so very, very limited side effects. Most patients do really well on it. Sometimes a little bit of fatigue, but other than that, it's doing really well. And it doesn't interact with your medication. So if you're already on an antidepressant and you're already on a blood pressure medication, well, using a device is not going to make give you some side effects from the combination of the medication. Some of the cons, the cost associated with them. Most insurance don't approve devices yet. It may change down the road, but there is a cost associated usually with the device itself and then with the treatment after that. So once again, that's something that we can always talk to our patient about, and it's a good avenue we can go with. All right. Now we're going to focus a little bit more on migraine-specific medication, okay? Now we have, like Dr. Corey said, there's been a lot more studies. We focus a little bit more on migraine-specific medication. The CGRP receptor antagonists, right? It's a big word. What does that mean? CGRP is a protein that's in our nervous system, and everybody has it, right? Everybody has that protein, but we know that migraineurs, people that have migraine headaches, have that protein in a bigger amount. It's just living at a higher amount in our system. So these medications comes in and kind of lowers that amount back to a normal range. Two medication I put here as prevention that are tablets. Rimogepant and atogepant, also known as Nurtec and Qulipta. Those medications are tablets. The Nurtec is a melting tablet. The Qulipta is a tablet that we swallow. And some of the advantage of them, they are truly migraine specific, right? They really help us. And they have very limited side effect as well compared to the older medication, right? Usually when we look at the data, very limited patients have side effects such as, and the side effects are usually related to either fatigue, drowsiness, or GI symptoms. We have some CGRP present in our gut, so it can give us some nausea, some stomach pain. But other than that, it's a medication that's usually really well taken by our patient. The downfall of it, I know patients here that have kids that have migraines. It's currently only approved for 18 and above. Does that mean that we don't use it? No, but sometimes it's a little bit of a battle with insurance if we failed a few medication. And these are medications that they're paid out of pocket, where insurance cannot help us, so we don't have coupons or copay card. It can be very expensive. So that's certainly something that's newer out there, right? It's not been around for 20, 30 years. It's something that's been around for the last 5, 6 years, and they're very good drugs. Next, we're going to talk about, once again, that CGRP comes back, right? But these monoclonal antibodies, those are those injections that we get, right? We see those commercials sometimes on TV about those like EpiPen-like medication that we inject once monthly. And then I have the galcanezumab, the erinumab, and the fremanezumab here, also known as the Emgality, the Aimovig, and the Ajovy. And those are monthly injections that we do, okay? So we don't have to take a daily pill anymore. Okay, we can do those monthly injections and then go on with our life. And this is there to reduce the frequency of our headaches. And once again, very limited side effects, right? Most side effects I tend to see are related to the injection itself. So it's still a needle, right, in the thigh most of the time. And then it might have some itchiness, some tenderness, some redness. But other than that, medications that have very, very limited side effects profile. Also, only approved from 18 and above, right? Same thing as the first category that we talked about. So very same negative, the cons associated with it. But like I said, from my standpoint, I think they're very good drugs. All these CGRP medications are very, very good drugs. I put eptinezumab there. That's also known as Vyepti by Lundbeck. They're here today. A little bit of a kind of a different approach. This is an infusion. This is not an injection monthly. This is an infusion that you do every 3 months. So once again, yes, it's an infusion, right? Where yes, there's a needle involved, but because it's an infusion every 3 months, a lot of patients like that aspect, that I don't have to take that daily pill every day. I can, or I don't have to take that monthly injection. I can go with a medication like the eptinezumab. And what we look, when we look at the data of this medication, because it's an infusion, it's within the system very quickly, right? Upon infusion, it's already in your system, so it can start working fairly quickly, okay? Some of the cons with that medication is that, once again, right, it's a medication that is very expensive if paid out of pocket. There are coupons, there are copay cards that are available. And I would certainly encourage you to, if it's something that looks good to you, to talk to some of your providers or some of your headache specialists to help you out, figure out what's the best treatment plan for you. Toxins, things like Botox, Xeomin, Dysport, those are some of the companies out there that have the toxins that can be used for these chronic migraines. I put there that it can be used for other things as well, right? We treat a lot of patients sometimes with cervical dystonia, where they have a lot of neck pain, there are a lot of tenderness, where their muscles in their neck are hard as the rock, and then that's kind of like causing some of their migraines. These injections can be done for that as well. And I'm not going to spend too much time on that, on those. Those are usually every 3 months. It's an injection, and it's about 31 injections for chronic migraines, right? 15 on each side, 1 right down the middle. And then we kind of cover the entire head. And then one of the advantages we have with toxins is that they can be used in combination with something else. So they don't necessarily interact with your medication. They have very limited side effects. So a lot of patients like that idea. I'm having chronic migraines. I've tried a bunch of medication. Nothing works. Well, you know what? Maybe we can start combining those medications and see if that can help you with your headaches. Then there's the non-migraine specific medication, okay? I'm going to touch on 3 main categories here. Medications have been around for quite some time. They are older medication. These anti-seizure medications have been around also for a while. I put topiramate there, gabapentin, pregabalin. Those are just some of the examples. The list goes on of medications that are anti-seizure medication. And when we use these medications, it's usually if it costs is very cheap. Okay, sometimes insurance will require you to go through these kind of stepwise approach, but sometimes it can also help with other aspects of your life, right? If we're trying to kill 2 birds with 1 stone, try to help with, for example, you deal also with neuropathic pain as well. Well, maybe something like gabapentin could help. You deal with something like restless leg syndromes. Well, gabapentin could help with that, right? You have seizures. Well, maybe topiramate could help with that. You have issues with sleep, or your topiramate was also used before for weight loss, for example. example. Those are kind of options, but when we look at a patient, everybody's a little bit different and everybody comes with certain baggage that want certain issues addressed. That's where these medications come into play. The next category, antidepressant, anti-anxiety medication, right? Dr. Corey really touched on that earlier, saying that, is it the anxiety that's causing your headache, or is it because you're having migraines that your brain is kind of on the edge and it's causing this constant anxiety? Am I going to be able to function today? Well, sometimes medications like anti-anxiety, antidepressant can come into play because it really helps us with not only the management of our migraines, but also the management of our headaches or anxiety and depression. The first category here, SNRIs, right? We have medication like venlafaxine, duloxetine, desvenlafaxine. Those are the Effexor, Cymbalta, Pristique of this world. They can really come and help with multiple aspects of your life. I put here as well the SSRIs, right? The fluoxetine, sertraline, the Zoloft, the Prozac of this world. They may not be as effective, for example, as the SNRI for the migraine management or the headache management. But if I already have a patient, for example, that's on a medication that they love for their migraines, but they're still feeling that their anxiety because of their headaches, or they're very afraid of getting those migraines, maybe sometimes we can work with that combination of medication. And these tricyclic antidepressant, right? Amitriptyline, nortriptyline, they're used quite a bit for the management of your headaches. They can help also with other aspects of your life, right? Not rare that I'm going to use some amitriptyline to help with sleep, for example. If a patient has tried the supportive therapy we talked about earlier, and we're still unable to go to bed, we're still unable to sleep, well, maybe a medication like amitriptyline can really help. The one thing I will say is amitriptyline, nortriptyline, we have to be careful. These medications should be avoided if you have yourself a history of arrhythmias or heart disease. I would certainly encourage you to talk to a medical provider at that point. My last slide here, these blood pressure medication. I'm going to go very quickly over them, but these are different classes of medication that can be used for the control of headaches, but also can help with your blood pressure, right? If you're somebody that deals with hypertension, for example, and you're talking to your PCP, well, maybe in the middle category, a medication like losartan would be something I would discuss with your PCP or your cardiologist or one of us, right? Medication that could help with your headache management, but it can also help with your hypertension. It's a medication like the beta blocker at the top, right? They are approved for the treatment of migraines. They are FDA approved for treatment of migraines. So it's something that we're going to use quite a bit at times to help with the headaches, but also, right, their blood pressure medication. They can reduce your blood pressure, make you feel tired, dizzy. Those are some of the side effects we want to make sure that we pay attention to. And the last category at the bottom, the calcium channel blocker. Those you may not see as often in the management of headaches. They're not necessarily our first choice when we go to them, but they have their place. They have their place. Patients that have circulatory issues, they have these things like Raynaud's syndromes where that discoloration, the fingers get white, toes get white, and then it's painful, cramping. Well, these medications can come in handy for us in treatment, and then you deal with headaches. We can reduce the frequency of those headaches. So these are just some of the categories of preventative. We hear all the time patients that will come to see us will say, I've tried it all. I've done it all. Trust me, there are hundreds of medications out there that can be used. For sake of time today, I could only touch on some of the categories, but I'd be happy to answer if there's any questions.
Are there any questions at the table over there? Oh, we have one question. Okay. I'm sure, okay. Oh, halfway through the tree. Halfway from the Jovi, how does saying, how does it stay in the body for a month? That's good.
Yeah. Not 100% of this one. Maybe Dr. Berenson, Dr. Corey would know that one. The question was, what is the half-life of a Jovi? I think 30 days. Yeah. So yeah, And that answered the second part. The second part was how does it stays in the body for a month? Well, the half-life is about 30 days. I wasn't sure if it was, you know, that's why it's done every month. And then I could say the same thing with, are you coming in?
So there's difference between half-life and therapeutic effect. So the therapeutic effect is the level above which a drug is effective. The half-life is the time for which the drug is divided by half in the system. So when you take a drug, if it gets up here, half-life brings it down here, it's still effective. Another half-life brings it down here, it's still effective. Half-life has nothing to do with how long it is effective. So do not mix these two. A lot of patients mix these two. So some drugs, this is the half-life, they're effective less than half-life. So half-life and therapeutic effect, no relationship, right? The half-life is how long does it take to divide the drug in half in your system. It's a purely theoretical concept that is pharmacokinetic to clear the drug from your system. The therapeutic effect is the level above which a drug is effective. So Ajovy stays effective for the whole month. And if you take 3 Ajovies, it stays effective for 90 days. Because now you have a whole lot more. Even though the half-life is 30 days, when you have 3 doses in your system, you divide it by half, you're above the therapeutic effect. You divide by half, you're still above the therapeutic effect, right? So I just wanted to make sure that everybody is clear on that.
Perfect.
Okay, thank you. Thank you. We're going to pause now, and there's a lot more questions. We're going to try to get to all of them, but we're going to take a break. We're going to come back at 11:20. And as I mentioned, Dr. Corey is sticking around, so we will get to these other questions when we come back. So the restrooms are out, down the hall, and all the way to the left. Please come back by 11:20. Everyone, we're going to get started. If you could find your seats. I want to introduce our next speaker, and I have good news. All 3 healthcare providers are sticking around for a Q&A. So that's really good because you've got 3 experts now in the room, not just one. So our next topic is going to be around abortive therapy. And I want to take a moment to introduce Dr. Frank Berenson, who is also from Southeast Center for Headaches. And Dr. Berenson brings over 2 decades of experience in pediatric neurology and headache management to Southeast Center for Headaches. Dr. Berenson began his professional education at the University of North Carolina in Chapel Hill. See, now you're all talking to each other because you all made friends, which is great, which is what I was hoping for. So I love that you're all chatting. But you're going to want to hear this. I'm telling you, it's going to be a great talk. Dr. Berenson earned his graduate degree at the University of Georgia and then enrolled at the same time in the Medical College of Georgia in Augusta and earned his Doctor of Medicine. After receiving his medical degree, Dr. Berenson moved to Ohio to participate in a pediatric neurology fellowship at the Cleveland Clinic. And at the end of his fellowship, he went on to go to Case Western Reserve University and Rainbow Babies and Children Hospital as an assistant professor of child neurology, both in Cleveland. In 1997, Dr. Berenson returned to the Atlanta area with his family, and over the course of the last 20 years, he's continued to augment his professional skills, gaining expertise in neonatal neurology, headache medicine, epilepsy, and neurophysiology. Dr. Berenson is board certified in child neurology and is one of only 3 doctors in the state of Georgia boarded for headache medicine, which is pretty sad. just so you know, we have a shortage of headache specialists all over the country. Dr. Berenson is also a proud fellow of the American Headache Society. He provides compassionate care in a warm, welcoming environment. His patients love him, and Dr. Berenson has earned the title of one of Atlanta's top doctors 6 years in a row. Sorry, just my page just ran away from me. Outside of serving patients, Dr. Berenson is actively involved in the care of neonates at Northside Hospital. He also enjoys contributing his expertise to clinical trials and drug studies related to the treatment of headache disorders and epilepsy, Tourette syndrome, and headache medicine, and is a published researcher. He welcomes any man, woman, or family seeking pediatric services or treatment for epilepsy to come to the Southeast Center for Headaches. And I want to welcome now Dr. Berenson.
Good morning. Pleasure being here. I'm going to load this up real quick, folks, because I can't see well enough to see the slides in front of me, unfortunately. So we'll go from there. Anyway, I'm going to talk about acute abortive therapies for headache, and we're going to try to comprehensively cover all the different treatment options we have, and that's a lot of stuff. And we'll talk about risks and benefits. There's really no best acute abortive therapy for anybody. It's really what works best for somebody and what's best for the specific headache scenario. So we'll talk about that. So what is abortive therapy? Well, it's any modality, maybe a medication, maybe something else that you can use at headache onset to relieve the headache. So we look at behavioral treatments. There may be oral medications, nasal sprays, medications we might inject subcutaneously, intramuscularly. They may be forms of neuromodulation like Simon mentioned, or infusions. So we have lots and lots of different options, and we really pick and choose based on the patient and what's going on with them and what their headache scenario is like. So what are our goals of abortive therapy? Well, and this is based on really a survey of patients who have migraines. Well, what we all want is we want that headache to be gone. Nobody wants to get their headache down from a severe to a moderate headache. We want the headache to go away entirely, and we want it to go away quickly. Most people would like to have headache relief within an hour or so. So if you've seen somebody and they're taking something and their headache is better in 6 to 12 hours, that's really not good enough. So freedom from headache pain is our goal, and then freedom from what we call their most bothersome symptoms. As I think Dr. Curry mentioned, for a lot of people, it's not the headache that's the problem. Headache is one piece of the pie, but a lot of people have pretty marked light sensitivity with their headaches. They don't want to be outside in the sun. They can't stand fluorescent light exposure. And that's a real issue, so we have to deal with that. For some people, it's noise sensitivity. You know, if I look at people during migraines, some people will hear a pin drop. Imagine being in a classroom, imagine being in an auditorium where there's lots of noise and you're so sensitive to noise that that's bothering you. And other people have significant nausea, vomiting with their headaches, and of course we have to treat that. And if you're like my wife, her biggest issue, she gets horribly dizzy and off balance during her headaches. So we have to deal with that. So it's not just a headache with migraineurs that we're dealing with, it's the whole sensory phenomenon. People with migraines have tons of sensations coming at them and don't modulate that very well. Second thing is people want to be able to return to normal function. I can give people plenty of medications to sedate them and put them to sleep. And if they're sleeping and they're out of it, they're not going to be bothered by their headache. What we all want to do is get rid of our headache so that we can engage, we can go out on a date with our spouse, we can go to our kids' game, we can go to the school event so that you can function in life. So that's critically important. And of course, people would like to just use one medication, treat one time, what we call one and done, and to have the magic bullet that will just take care of everything and not have the headache come back. Because unfortunately, a lot of our medications, they work really good initially, and the headache's gone for 6, 12 hours until the next day, and then boom, the headache comes back again. That's not what we need. And of course, nobody wants side effects. And unfortunately, most of our medications have side effects, and so we'd like to eliminate that. So we pick and choose based on this. Now, what's remarkable to me is how many people don't take their medication when we'd like them to take it. We always recommend early treatment as soon as possible. People delay treatments, and they delay for a lot of reasons. One, I don't know if my headache's going to be a migraine, so I better wait and see. or 2, I don't know how bad it's going to be, or 3, if I take that medication, I'm going to feel really lousy. I'm going to have lots of side effects, so I'm going to hold off on taking medication. Or 4, my pharmacy or my formulary plan only gave me 4 medications or 4 pills this month. So people hoard their medication. They want to save it. So ideally, we'd like to be able to treat as early as possible and educate people to do that. So I'm going to go back on lifestyle changes, because if we can avoid triggers for patients and for ourselves, we may not need to use that acute abortive therapy. So whenever I see somebody, we kind of cover the gamut of sleep. Everybody needs to get more sleep than they're getting in general. And if I'm looking at teenagers, they need more sleep, 8 to 10 hours a night. They always get less sleep than that. They've got too many activities, they've got too many AP classes, they've got the extra school, and school's very demanding. But working on a schedule with patients, working with families, make sure people aren't overscheduled in their life, very, very important. We talked about water intake and hydration, and that's probably the easiest thing that we can all do. If we would just hydrate more, it really makes a big difference. Regular eating habits. If I see people who are skipping breakfast or not eating until 1 in the afternoon, you'll have a little dip in your glucose. And for somebody who's got an unstable nervous system anyway, who's got a hyperexcitable brain, that's probably enough to just kick them over the edge and trigger their headache. And then, of course, we avoid food triggers. Probably the most common food triggers I see are things like MSG, maybe nitrites, artificial sweeteners, too much caffeine. We've covered those. So watching those things. Exercise, getting people to exercise regularly 3 or 4 times a day. I'm sorry, 3 or 4 times a week. Times a day would be fantastic. That's back to college for me. But getting people to exercise, if nothing more, for just stress relief. And then stress management, and Dr. Steiner's going to talk about that quite a bit later. But stress management is so important for all of us, I think, and identifying our stressors and knowing how to manage stress, really critical. So what are our acute therapies that we have? And we're going to start as kind of a big class, and then we'll talk specifically about some of the drugs that are out there. Well, the behavioral management, I think, can be very, very important. And often if you can get somebody to behavioral therapy, you may not need acute abortive therapies or acute abortive medications, or you'll need them much less. So working on relaxation exercises, cognitive behavioral therapy, teaching people visual imagery relaxation exercises, breathing exercises, all these things can be hugely helpful. We've got tons of different oral medications or intranasal medications or injectables that we can use. There's different forms of neuromodulation that have come to the forefront recently, and some of them can be very helpful. Sometimes we use IV infusions. We'll talk more about that. And sometimes nerve blocks. So these are all different avenues that we can choose for treating people who have a hyperexcitable brain. So what's going to be our best treatment? So what do I choose for somebody? Well, there is no best treatment. There's lots of different treatments for lots of different occasions. So a lot of it depends on what I know about somebody's headache. So it's very important to talk to people, find out what's going on with them. So if I have somebody who wakes up with a headache, I don't know when that headache started. It started in the middle of the night sometime. I'm going to have to be more aggressive because that headache's been going on a lot longer, likely, from a physiologic standpoint. So we may need to step things up. If I see somebody who's got a really bad headache, I want to use something that's going to be a little bit more potent, if you will, something that might be a little bit more migraine specific that I think is going to be having a better success of getting their headache under control. When I see somebody who's got a rapidly escalating headache and they're going from 0 to 100 on a headache scale in 30 minutes to an hour, I need something that's going to work very quickly for them. So something that's much faster acting. If I see somebody who's got a very slowly progressive headache and it evolves over several hours, they may do perfectly fine with an oral medication. If somebody's got a lot of nausea and vomiting in association with their headache, and we've already talked about GI dysfunction, a lot of patients with migraine have gastric dysmotility. Their guts don't work well, both during their migraine and also in between migraines, their guts don't function normally. They're not going to do well with an oral medication. And then we may want to look at a nasal spray or an injectable medication. And then, of course, if I'm looking at somebody who's younger, they may not be able to swallow a medication, so I may need to use a different route of administration. So all these things come into play. So let's talk about some of the oral medications. We've got tons of different oral medications. There's tons of over-the-counter drugs. Some of them can be very effective, some less so. We've got prescription medications. We'll cover them. Probably the most commonly used medicines we see are the non-steroidal anti-inflammatories, ibuprofen, Excedrin, or naproxen. And these medicines for somebody with a mild or even sometimes a moderate headache can work pretty well for people, but they're probably frequently overused. They're inexpensive. People get them, and I see people that are taking these 3 or 4 times a day, and certainly that's not healthy and frequently causes problems with what we call medication overuse. Tylenol is frequently used, and I think it's probably the least effective of our oral medications out there, and I think we all should step to other medications before that. Aspirin's an interesting drug. There was a study published about 20 years ago in one of our headache journals comparing aspirin. It was a European study comparing aspirin to one of the triptan medicines, or sumatriptan, which was kind of our gold standard at the time. And for mild to moderate headaches, aspirin actually works very nicely. The problem was when we looked long-term with people using aspirin, tons of side effects with the medication, mostly gastritis, ulcer development. So even though we see aspirin marketed all the time, BC powder, goodies, Bear, all these things, and they work for headaches, they have lots and lots of side effects. So we try to avoid overuse of those. But if I see somebody who's using an aspirin once in a while and it works for a headache, I have no problem with that. If I see somebody using Excedrin and they're using it once or twice a month and they get headache relief, fabulous. That's great. That's a great option for them. But for many patients who are having more frequent headaches, that's not a good option. We'll come back to triptans in a little bit and talk about them in a little bit more detail. Triptans have been around since the early 1990s, and I was finishing up my training and just starting to practice around that time at the Cleveland Clinic Foundation. And triptans, or sumatriptan, had just come out as an injectable. It was the first migraine-specific acute abortive medicine that we ever had. And we would have patients come in to the clinic with a severe headache, get an injection of sumatriptan, and go home in an hour without a headache. It was a life changer. It was really, really remarkable for these patients. And it also justified the disease of migraine. Migraine was no longer a disease of hysteria like CK mentioned earlier. This is a pathophysiologic disorder that's often genetically based. And now we had some proof that demonstrated that. There's an old group of drugs called ergots, Cafragot, DHE, that have been around, since the 1940s that have been used. And then we have our new class of drugs, which I think have been remarkable, and we'll talk about them a little bit more. And these are what are referred to as G-PANTs, and you've seen them advertised on TV. Ubrelvy and Nurtec, Lady Gaga, and the tennis player, what's her, Serena Williams, I think, advertises for one of them. And the G-PANTs target a different site in the brain for migraine and have been remarkably effective. There's a group of drugs called ditans that have come out recently, and there's one drug in this class right now that's been helpful, and it's probably the most undermarketed and underutilized drug I've seen, but has lots of side effects. And then there's the anti-nausea medicine. So adding on Phenergan or Compazine or something like that can really be really very beneficial. So let's talk a little bit about aspirin, because aspirin's been around forever. At high doses, it's pretty darn effective. It's got an anti-pain and also an anti-inflammatory effect, but lots of side effects, mostly stomach irritation. So people don't tolerate it very well. So in general, we try to avoid that. Likewise, in young kids, we don't like to use this medication. There's a condition called Reye's syndrome, and Reye's is a disorder that's been linked to aspirin in kids who have a viral illness or a febrile illness. And it's a very serious condition, and these patients develop headaches, lethargy, nausea, vomiting, possibly seizures, liver dysfunction, and swelling of the brain. So it's a very serious condition. So we avoid aspirin in young kids because of that risk. Tylenol, as I mentioned earlier, pretty nonspecific for headache. I think it's got a marginal benefit and infrequently helpful by itself. So in general, I recommend using other things. Non-steroidal anti-inflammatories. Well, there's tons of them out there. Excedrin migraine, Advil migraine, and all of these are largely combination medications, either ibuprofen or acetaminophen and aspirin and caffeine. So it's a combination of different over-the-counter medicines. And these can actually, well, the non-steroidals are different, but the combinations have a non-steroidal in them. They can be very effective. But again, people frequently overuse these medications, and they think because it's over the counter, I can take this a few times a day, it's perfectly fine. And then the overuse medicine, it actually makes the headache worse over time. Triptans, we've got 7 different oral triptans, and you guys have probably all heard of many of them, sumatriptan and rizatriptan probably being the most commonly used ones, but they're different. So all of them come as an oral medication. And for people who have kind of slow onset headaches that progress over a few hours, I think the oral medicines work pretty well, but in general, they're slow acting, so they don't kick in super fast. There's also the oral melt tabs. So there's rizatriptan and Zomig come as a melt tab. So if I see somebody who can't swallow a tablet, the oral melt works very good. If I see somebody who's got a lot of nausea, they may do better with an oral melt tablet, and I'll use that. Interestingly, a lot of people think the melts are going to work better or work faster. They really don't. The oral melt, it melts in your mouth, you swallow it, it's absorbed in your gut. So it works about the same as an oral tablet as far as speed of onset, but it may be easier to take for some people. Nasal sprays have been, I think, very helpful for many people. And the nasal sprays, there's a couple different drugs that come as a nasal spray. You spray it into your nose and they're absorbed up in the bulb of your nose, which is a highly vascular region. So it's absorbed in your nose. You get a high level of medication very quickly, and they work much faster than the oral medications. The downside to the nasal sprays is 1, they burn, 2, they taste really nasty. 3, a lot of people just don't like to spray things up their nose in our country. And my daughters have used these and they can't stand the taste and they won't use it because of the taste. And the taste just, although I like the nasal sprays, they work pretty quickly. Some people just don't tolerate them. There's one injectable on the market, and that's sumatriptan. And sumatriptan, again, has been a lifesaver for many people, but a lot of people don't tolerate the fact they have to give themselves an injection. But for a fast-acting triptan medication, you can't beat it. It works very quickly. The problem is sometimes the headache rebounds and comes back after 6, 12 hours or the following day. And then there's some long-acting triptans available. The long-acting triptans have been kind of characterized as a little bit smoother, a little gentler. If I'm seeing somebody who's elderly and I'm concerned about more risk factors with triptans, I might use one of the longer-acting medications. If somebody's got a very protracted headache, the headache's going on for several days, like a menstrual migraine potentially, I might use a longer acting triptan because it's going to hang around a lot longer and they may have a better long-term sustained response. Briefly, I'll mention ergots, and these are DHE or dihydroergotamine preparations. Migranol was a nasal spray that's been around for years. Migranol was intranasal DHE, and unfortunately wasn't a great headache treatment. The absorption was very poor and people didn't do very well. So a few years ago, a similar medication came out called Trudhesa. And Trudhesa has an aerosol that shoots it up your nose, up to the upper part of your nose, has much better bioavailability because of where it's delivered. People have done much better on it. And then there's another form of DHE that's given intravenously. Excuse me. And right now, IV DHE, there's a shortage, so we're having a hard time giving that. But DHE works very nicely. It has a direct effect on a certain brain receptor called a serotonin receptor. It also affects a couple neurotransmitters in the brain, so it can affect signaling of brain pathways, and it constricts blood vessels. But because of the vasoconstriction that we see with this, it's contraindicated in a number of patients. So if people have coronary artery disease, they've got peripheral vascular disease, so especially our elderly population, you have to be careful with this class of drugs. And the side effect of the IV medication has lots of treatment side effects when we give it IV. So it's usually given IV in a hospital, so it's not an easy thing to use, but it has been very effective. Gepants are kind of the newest medications that have come out for migraines, and these are a migraine-specific medicine. Simon alluded to these briefly, and they target a protein in the brain called CGRP. And CGRP was identified back in the early 1980s, and then there were studies done in the late 1980s looking at CGRP and looking at levels, and somebody has a migraine headache, their CGRP level goes up, and you can measure that in their blood. So somebody said, gosh, that's interesting, maybe CGRP is causing headache. So fast forward about, probably 20, 25 years, and we now have new migraine-specific medicines that specifically target CGRP. And these are the monoclonal antibodies. that mostly bind up the protein, although one of them blocks receptor. And then we have these other medicines called GPANs. And when CGRP is released from nerves, CGRP binds to receptor. And these medications block the receptor. So CGRP can't kick off this cascade of events that causes a migraine headache. And these have been remarkably effective. American Headache Society came out with a statement early this year saying that these should be first-line medications for migraines. And we like them as first-line medications, but insurance companies don't like them as first-line medications because then they would have to pay for them. So it's a little bit of a frustration, but we're making progress. And these medicines work very nicely, and we like them because their side effect profile is minimal and their safety profile is fantastic. They don't really have any significant safety concerns. And these come as an oral tablet, as melts, and as nasal sprays, so they're super easy to use. And the ones you'll see is Abortive or Nurtec and Ubrelvy, and they both work very nicely. But we can't use them under age 18 because they're not FDA approved. So what is a ditan? A ditan is a new class of drugs that targets a different serotonin receptor in the brain. So it's kind of similar to the triptan medications, but targets a different site. And the one that's available now is something called Rayval. And again, this medicine, although I think it's remarkably effective for patients, has been marketed very poorly, and it's really underutilized by most neurologists and headache docs. And it works well, but it has side effects. And the biggest side effects is drowsiness and dizziness. So there's an FDA warning that you shouldn't take this medication within 8 hours of driving. So you can imagine if you're at work and you want to take medication, well, that's a problem. How am I going to get home? Or if I'm going to go home to my kids and I'm going to be sleepy, that's not good. So we really kind of reserve this medication for using late in the evening after people have gotten home from work, but it does work very nicely if they tolerate it. And it's not FDA approved under age 18 at this point. Combination treatments. So if I have somebody who's not responding well to a single medication I give them, I'm going to give them something that might be complementary, that may target a few different sites in the brain. So we use different classes of drugs together. If I've got somebody who's on a triptan, like sumatriptan, and it helps their headache, but it doesn't relieve their headache, I may add a GPAN to that, or I might add a nonsteroidal to it. So we use medications together to work synergistically for their headaches. And I frequently throw on an anti-nausea medicine because anti-nausea medicines, in addition to helping with the nausea, also have anti-migraine properties. So using them in combination with other medicines can be very, very effective. IV infusions. Well, these aren't so easy because you've got to either get to an IV infusion center or you have to get to our office to get an infusion. But for people who are having protracted headaches and aren't responding to their oral daily medications, and I get a call and John's been at home for 3 days and has had a severe headache and he's been taking his medicines and still has a headache, I'm going to bring him in for an IV infusion. With an IV infusion, we use a cocktail of medications, usually a steroid and a nonsteroidal, usually an anti-nausea medicine, perhaps magnesium, and maybe one of the seizure medicines with this, and we give it intravenously, and we have a much better chance of getting headache relief. If I've got somebody who's had a protracted headache that's been going on for days, sometimes it takes 2 or 3 infusions, or sometimes a couple days of IV infusions. Nonetheless, it can be remarkably effective in people who have what we call status migrainosus, which is a protracted headache. And then nerve blocks. Nerve blocks are something we do very frequently in our office, and most headache specialists do them. We found them to be very effective, both as abortive therapy and preventive therapy. And we use a topical anesthetic like xylocaine or bupivacaine or Marcaine, and we inject them selectively over nerves in the head to calm down the nervous system. And these can work very quickly, and we frequently see headache response or improvement the same day or over a couple of days. The downside is they hurt, and some people just don't tolerate them. And bottom line is they do hurt, but I nonetheless find them very helpful. I think this is the last thing I'm going to cover, some of the new devices. And there's something called an Nerivio device that is something you wear on your arm. There's a Cephaly that's like a little tiara that stimulates nerves right here on your forehead. I haven't found it to be horribly effective. There's something called a GammaCore, which is external vagus nerve stimulator. It's a little handheld device. You hold it up to your carotid right here, and your vagus nerve travels right there, and you stimulate for a couple minutes several times a day. that can actually break migraine headaches, but the product itself is horribly expensive and not covered by insurance, so virtually nobody uses it because of the costs. And there's even a magnetic stimulation device called the TMS, or transcranial magnetic stimulator, that can be used for people with migraines with aura. I'm going to pay a little attention to Nerivio because I think this has been a great new device for us, and it's affordable, and it's a little armband you wear on your arm, and you can use it either for headache prevention or you can use it when you get a migraine headache. And I think for people who are intolerant to medicines or have side effects or who don't want to take medication, this is a great option. And ultimately you wear it and it stimulates your arm for about 45 minutes and it has an effect on blocking pain pathways in the brain. And the data is actually remarkably good. And I've had a lot of patients who have done very nicely with this. So I'm a big fan of that. I've got a couple minutes to talk about a couple cases, so we can just talk about how we would pick and choose. And this is a 14-year-old girl who came in with infrequent episodic migraines in the past. She started back to school this fall, and since August, almost every Monday morning, she has a bad migraine headache. And this wasn't the case over the summer, it wasn't really the case last year. And she has nausea and vomiting with her headache. So first of all, what do I do with that? Why is she having headaches Monday mornings? So we have to look and say, what's different about Monday than every other day of the week with her? So yeah, certainly question, is it school stress? Does she have a class that day that's really hard for her? Did something happen over the weekend? Is she got a change in her diet? Does she have a change in her activity? Is there a change in her sleep pattern? So all these things have to be considered. In fact, this was my daughter about 15 years ago. And when we explored this, because she was missing school every Monday, it was very frustrating, found out that, well, when she got back to school, she was going to sleepovers every Saturday night with her girlfriends, staying up till 3 or 4 in the morning. She was sleep deprived Sunday, and then boom, Monday morning, has a horrible headache and missing school. So we made some modifications with her sleep and with her behaviors with sleepovers, and that pretty much took care of the situation. So again, addressing the cause of the headache or the trigger of the headache is hugely important. If that wasn't the case, how would I treat her? Well, she's waking up with a headache. I'm probably going to use a nasal spray that's going to work faster and give her a nausea medication. So I'll probably use a migraine-specific nasal spray like sumatriptan nasal spray, a Zomig nasal spray, because they work much faster, and give her a nausea medicine with that. It's another case, 23-year-old who has frequent migraines. He has moderate to severe headaches. He's tried a few triptans, had side effects on these, and they didn't work well. What are we going to do next? Because he wants a different abortive. Well, we know from studies that if you fail 2 or 3 triptans, you're likely not going to do better on the 3rd or 4th one. So switch drugs and either go to a different, newer drug like one of these G-PANs that we talked about, Nurtec or Ubrelvy, or try one of the forms of neuromodulation that might be helpful for him. And the last case, John has infrequent migraines, but for the past few days, he's had a severe headache. He's been taking his routine medication at home like he's supposed to. He's taken sumatriptan regularly for several days. He's taken anti-inflammatory with it, taking his non-addict medicine. So what are we going to do? Well, it's time for more aggressive care, and he's somebody who needs to come into the office or go to an infusion center for IV medication so we can knock out his headache. And I think I am out of time and out of slides. So hopefully that gives everybody a little look at different options we have and situations that we use different treatments for. Perfect.
Get some chairs. We're gonna, that was excellent, right? And there's like, I can't believe how many questions you all have. We're gonna try to get to all of them. We're gonna ask the doctors to come stay up here and bring a chair. Yeah, throw some chairs up here. Yeah, we'll bring them back here. I can answer all the questions. I don't put them all. Or do you want me to read them? There's one. We're gonna have to take this off and we're gonna share the mic, pass it around.
So I would say
You all read them. Okay. All right. I've never had this many questions at an education event ever. So I hope that we're going to get to all of them, but we're going to try. Okay. The first question is, I hydrate well, but I get migraine when I exercise. Is there a specific kind of preventive that I should try to ask my doctor about? Try it.
Oh. Can you just repeat the question?
Okay, exercise prevention. I get migraine attacks when I exercise.
So there are some patients actually that will get these types of headaches, right? We call them exertional headaches. They will come to us and they'll say like things like, "Well, I get these migraine headaches, but it's always when I'm active or I'm exercising." If we're able to identify, in terms of prevention, if we're able to identify a certain exercise, then we try to avoid that exercise, right? I've had patients before telling me, well, it's every time I do, weight workout where I do like, leg press or bench press, or if it's intensity related, that's also important, right? If we realize that is something that every time I push my heart rate to a very high level, that is certainly something that we want to approach. In terms of prevention, is there a certain preventative medication? Multiple classes of medication can help with that. The one thing I will say though is that if it is related to intensity, for example, if you're a patient that every time your heart rate go above a certain level or your blood pressure goes a certain level, I would certainly encourage to meet with one of us at an appointment, because there's certainly things that are important to rule out as well.
Okay, thank you. Yeah, I'm going to say keep your, and also, yep, that was perfect. We're going to keep them as brief as possible. That was perfect. Okay, I haven't ever had a rescue medicine that works. What should I do? What's your advice?
Okay, well, we'd have to go through a listing of all of your rescue medications and see whether there's something new to offer you. And frequently, it's not one medicine. Again, frequently it's combination medications. And you have to pick and choose what's going to work best. And it's trial and error. There's no right medicine for any one individual. It's finding what's going to work. And we always keep pushing to find the right thing. The other thing is a lot of patients will do better if they're on a preventive medication, because their acute abortives will work better for them. So preventives not only decrease the frequency of the headaches, but also frequently make the headaches more manageable when you take abortive medication. So they kind of settle down the nervous system and block the neuronal excitation. And everything we're trying to do from a preventive standpoint is to calm down the brain and really readjust your nervous system and normalize that nervous system that's hyperexcitable.
But yes, there are patients who at early stages, nothing works and you just have to sleep it off and it sucks, but it is what it is. Yes, they exist until we are able to calm it down.
Okay, this question is a two-part question. Can migraine cause a chronic cough? And is it common to have migraine disease post-menopause? Yes. Do you treat this differently than another type of patient?
The only thing is that we don't focus on hormones. That's the only difference. Otherwise, it's the same. Treatment is the same, right? Post-menopause.
Right.
Yeah.
Yeah, I think there's a misnomer. Everybody thinks that for women, they're going to go through menopause and their headache's going to get better. That's usually not the case. If I have somebody who only has menstrual migraines, when they go through menopause, they're not having menses anymore. They're not having those hormonal fluctuations. They may get better, but for the majority of women, this is a lifelong disease. It doesn't go away.
And what about cough? Have you ever heard of patients with a chronic cough due to migraine?
I haven't.
Okay. Is there, if there is, the connection between ADHD and migraine?
So there's no direct link between ADHD and migraine per se. There's a link between migraine and brain fog, and brain fog is the same as ADHD inattentive type, not the hyperactive type. So yes, people with migraine get often diagnosed as ADHD inattentive type because they cannot focus, they cannot sustain attention, but that's because of that migraine fog. Now, we do that also because otherwise we cannot get the medicines for them. So because of that brain hyperexcitability, you cannot focus and sustain attention. That's the ADHD inattentive type.
Thank you. Okay, here's the biggest question that so many people want to know. Foods, are there foods to avoid? Or do you think foods can be triggers?
Well, Dr. Berenson actually touched a little bit on some of them. There are some food groups that have been identified to be linked to more headaches. Food groups such as, well, alcohol is one of them, and I touched on that. Dr. Berenson touched on the nitrates, touched on the MSGs, fast food. Um, there's a lot of people out there that would love to find their exact trigger. And it's way easier said than done. And I usually have this conversation with all my new patients at the first visit. I tell them, how about if we can find exactly what's causing your headaches? Trust me, I want to find it and I want to get rid of it. But in most cases, it's multifactorial. We talked about genetics. We talked about there's more than just one thing that's causing the headache. And that's the frustrating part with treating headaches, right? We always joke around. If you have a cardiac problem, you go see a cardiologist, you're going to do tests X, Y, and Z, and then you're going to know what you have, and you're going to have a medication, and you're going to be good. When it comes down to neurology, at times there's a lot of unknown, and because migraines are multifactorial like this, it's hard to pinpoint exactly. But yeah.
I just want to say
Okay.
something about this. If you have a food trigger, you wouldn't be in my clinic. You would have identified that a long time ago, that every time I eat X, I have a migraine, and on your own, you would have eliminated X and you would not be in my clinic, right? So there are people who have food triggers. They exist, and they're done. If you're in my clinic, that's because you did not identify food trigger and stop looking. Stop. You're exhausting yourself, you're exhausting your family, you're draining your brain power, looking and looking and looking and looking, and your migraine, unfortunately, is not the food-triggered migraine. And let's focus your energy on something else.
And could you also talk about chocolate?
Oh, chocolate is the big one. Chocolate is not a migraine trigger, right? So do they exist? Are there people out there where chocolate is a migraine trigger? They exist. Of course they exist. There are people who exist where sea sand is the migraine trigger, right? People who have a specific migraine trigger, they identify it. They don't need me. They've noticed that every time I do X, I get a migraine. You don't need a specialist to tell you that. Past that, these are not triggers. So moms, please do not tell your kid, don't eat that, because I read on Google that some person wrote in Russia and another one in North Korea that their kid has X a trigger. No, if your kid has that, if your kid gets a trigger every time he or she eats this, great. Other than that, let them live their life.
But is it true that chocolate is actually a prodrome symptom?
So we didn't approach that a lot. We didn't have time to talk about prodrome. In prodrome, there's a lot of symptoms that get exacerbated. One of them is cravings. So you get a lot of food cravings. So historically, you crave a lot of the foods that are high in serotonin because your serotonin drops in the prodrome. So you want nuts, you want chocolate. So historically, it was thought that chocolate and nuts are a trigger because you eat them and boom, you have your migraine. Well, it turns out you're craving those. Whether you eat them or not, you're going to have your migraine. And that's why they're not food triggers. They're your cravings during the prodrome. So now we say, actually, if you eat enough chocolate, you may abort a migraine before it happens. I'm not advocating for that. You'll all be obese. And obesity is a risk factor for migraine. So don't do that. But do not fear chocolate.
Okay, perfect. Why do I wake up with migraine? And then what about, you mentioned aggressively treating when a person wakes with migraine?
I couldn't hear the second part of that.
Why do you need aggressively treating when you wake up with migraine?
Well, migraine is frequently, probably 25% of migrainists will wake up with their migraine headache. And I think it largely has to just do with circadian patterns. And that's when migraines develop. And there's sleep changes with the brain. Brain changes dramatically during sleep. So if somebody awakens with their migraine may have developed 3 or 4 hours before during sleep. So ultimately, we want to treat migraines early because they respond better when they're treated early. If they're waking with it, we don't know when it started. They're going to do better with more aggressive treatment. And frequently they're more severe when they wake up with them.
Non-oral by then, right? Because by then the gut is so slowed down, absorption is so not good. So you want to go to injectable and intranasals and stuff like that by then.
When you talk about the phases of migraine, is there a relationship to time with the phases?
I don't understand what.
So in other words, when you've got, you know, the four phases, yes, is there typically a timeline
No,
attached
not
to
at all.
that?
Not at all. Some people's prodrome is 20 minutes, some people's prodromes is 2 days. So there's no time for those.
Can migraine cause brain damage?
This is a very interesting question, and it has been looked at front and back and all this kind of stuff. Short of the strokes, right? Migraine with aura has a tiny risk of stroke. So we're not talking about that. If you have a stroke, you have a stroke. Of course, there's a brain damage in that. Just the migraine itself, with the chronic progression and repeated attacks, there is iron deposition in the brain, and there are these white matter changes. So far, we're not really sure what this means in the long term to the brain itself. There is some preliminary data that after decades, there's a little bit of drop in an IQ. But after decades, all of us have a little bit drop in our IQ because we're aging and all of that. So not in the short term. So in the short term, no, there's no damage. So your kid who in 6th grade was first of his class and now in 7th grade is not, that's not damage from migraine, right? So that's not migraine. Now in the long term, there is probably a little bit of damage, but it's not something significant on a day-to-day basis.
Okay, did Nurtec start as an abortive medication or a preventive?
Okay. Nurtec was initially developed as an acute abortive medication, and then they had data to suggest that it could also be used as preventive therapy, and there's newer data coming out soon, and it's actually been very effective for both. But
Okay,
it was initially designed, the study was designed as an acute abortive treatment.
okay, Simon, you mentioned magnesium before. What kind of magnesium do you recommend?
This is what I tell my patient. Maybe they have a different, I usually don't care as much. The second part, you know, there's glycinate, there's citrate, it's usually the absorption. So sometimes what I will say is that if you do have a lot of side effects with one, it's making you feel very tired or you're having GI issues, you could try a different one. But in terms of like, which one should you start with? How about the one that's easier access to? And then go from there.
Okay, thank you. And by the way, we're cutting into our lunchtime right now, but I think that you might be in agreement. We don't need as much time as lunch as we probably realize. So we're going to use this time and we're going to stop at 12:15. Okay, so please explain how gabapentin helps migraine.
So that's a question for all the preventives. So all the preventives do exactly the same thing. They quiet down the brain. From the beta blockers to the GABA drugs, to the antidepressants, to the anti-seizure. They all work on different receptors that allow the neuronal functions to quiet down. So gabapentin is working through the GABA, the beta blockers are quieting down the sympathetic nervous system, the antidepressants are working through the serotonin norepinephrine or through the tricyclics, which work on multiple receptors. So all of them are exactly doing the same thing, blocking specific receptors to quiet down the function of the neurons.
Okay. Can you share ways to sample the devices prior to purchase? I don't know that you guys can answer this question, but I think you have them in your clinic.
So yes, kinda yes, because Cephali will give you 2 months for free if you return it within 60 days. The others, you can't, I think GammaCore has some kind of program like that, no? That's starting a program like that. The problem is that you have to buy it and you have to do it for 2 months. Sampling doesn't work. Anytime you're trying to use a preventive, you cannot sample it and then say it's not working. We see that in clinic all the time. Patient comes in, it's like, I've done amitriptyline for 10 days, gabapentin for 1 week, topiramate for 2 weeks, nothing is working. I'm like, whomever is sitting you is stupid because these drugs don't work like that, right? We're trying to quiet down the brain. You will never tell a patient, here's the Prozac, call me next week if your depression is not better. Nobody will ever say that. And yet they do that for migraine. It's the same concept. I'm quieting down the brain. They don't work like that. The only drugs that have immediate response are the anti-CGRP. And not for everybody. So even with the anti-CGRP, we still say you do the 2 months, with the promise that 80+% will have an immediate response. But if you don't, you're in that 20%. I don't know if you're going to be in the 80% or in the 20%. You're still committing the 2 months. So that sampling is useless. You have to get the device. You have to do it for 2 months, at least 2 to 3 months. So you're paying for it, and then it's sitting in your drawer, unfortunately.
Okay, is there any research using GLP-1 medication for migraine? I heard it works for idiopathic intracranial hypertension.
Yeah, it's being looked at, as I think is a really interesting question. And certainly there are patients who are having benefit from the GLP-1 medications for their migraine headache. It's not something I'm using at this point in time, but it's being looked at. And I think it's probably going to be beneficial.
It goes both ways. There are people where it exacerbates their migraine, but there is data that it's anti-inflammatory, so it can help migraine. So if you meet the requirement of the BMI, I'm prescribing it for my patients. I'm not doing PAs and stuff like that for it. So if your insurance doesn't cover it, you're on your own, because my staff is not set up for these kind of drugs, but I am prescribing it.
Okay, this is a question for Simon. Why does caffeine help me with my pain? Not a coffee or caffeine lover. I have headaches every day, and as the day progresses, it becomes a migraine.
So, so there's 2 questions here. The first question is, why is caffeine helping? Yes, caffeine, I mean, we see caffeine in Excedrin, for example, in medication. It is a vasoconstrictor, and then Dr. Corey kind of touched on that a little bit earlier about how originally the idea of migraines was a vascular disease. Well, we know that it can be also caused by these vasodilation of blood vessels for some people, not for everybody. That's not always the case, right? It's multifactorial, but there's caffeine intake can constrict the vessels. The second part was?
Well, I have headaches every day, and by the end of the day, progresses into migraine.
Okay.
I'm going to totally disagree on that. So yes, there is a vasoconstrictor effect, but that's not the cause. He said that for some people, that's the cause of migraine. That's not the cause of migraine. So the reason caffeine can work for migraine is because it works on the adenosine receptor, which by blocking the adenosine receptor, it quiets down the nervous system. Yes, it also has a vasoconstrictive effect, which can also help, but purely vasoconstricting the blood vessel does not treat migraine. So just giving people a vasoconstrictor with nothing else is actually not a migraine treatment. So being a migraine abortive, it helps as an abortive. The problem with caffeine is that, like any abortive, if you abuse it, not because you're abusing it because you're abusing drugs, but if you're overusing it because you're in pain and you end up using abortives a lot, you develop what we call medication overuse headache. So that worsens your migraine. So if you take ibuprofen every day, if you take triptans every day, that leads to increase in headaches. And that's why overusing caffeine can worsen your headaches, because it's an abortive. I'm sorry, Simon.
What about other stimulants? Somebody wants to know, do stimulants increase excitability of the brain? So caffeine would be one, but what about ADHD medications?
No.
Can that make it worse?
No, actually no. So stimulants can help migraine. If you remember, people with ADHD, because their brain is up here, stimulants actually help quieting them down, which is a difficult concept to understand. But when you have dysregulation of the nervous system, sometimes increasing norepinephrine and dopamine allows the nerve cells to reset, if you want. So this is why kids with ADHD and they're hyper, you give them stimulants and it quiets them down. Kids without ADHD in college take stimulants to increase the activity of their brain to be able to study better. But kids with ADHD, it calms them down. So caffeine in a hyperactive brain actually helps quiet down the brain.
How can rebound headaches from nasal IM triptans be handled or prevented? I come from a country that doesn't have a long-acting triptan available.
Okay, So if somebody's got a rebound, we sometimes will use a short course of steroids to allow them to essentially detox from whatever medication is causing their rebound. Sometimes we'll add a preventive medication uh, to help with rebound. But ultimately, I think rebound is a real issue for people. And when you look at, brain pathophysiology, anybody can develop a migraine headache. So if I sleep deprive somebody, I give them enough caffeine, enough alcohol, anybody can get a migraine headache. So everybody has a different threshold for migraine activation. And so you have to jump this high to kick off your pain receptor. People who have migraine headaches, their threshold for activation is much lower. It doesn't take much of a stimulus to kick off their brain because their brain is hyperexcitable anyway. So their threshold for activation is much lower. When you've been on a daily medication or you're overusing an acute abortive medication and you have rebound, your threshold for activation drops. So those pain receptors are kind of on overdrive. They're hyperexcitable. It's easier to kick them off. So you ultimately have to detox from whatever the offending agent is. And then we try to give them something else in the meantime, whether it be a steroid pulse or putting them on a preventive medicine so they can get off that medication. And ultimately, you just have to get off the medication.
Okay, while we're on the topic of rebound, someone is taking a triptan almost daily. What are the risks of taking an almost daily triptan?
So the theoretical risk is vasoconstriction and heart attack and stroke. In reality, there's been a lot of studies done that show that the constrictive effect of triptans is so minimal. So unless you have severe atherosclerosis, that risk is minimal. So there has been studies of daily triptans as a preventive, probably not for life, but for months, as we're trying to detox them from other stuff like Fioricet, which is the worst of drugs. Do not ever get on Fioricet, but that's a different topic. So that risk is in migraine patients are typically healthy otherwise, so they don't have much in terms of atherosclerosis. So we could use long-acting triptans daily for a period of time because that risk is actually really, really minimal. So when triptans first came out, for example, we were like, oh, do not ever use them in pregnancy because the vasoconstriction is going to cause miscarriage. And it turns out that now they're our safest drug in pregnancy because there's really not much in vasoconstriction. And because pregnant women tend to not have atherosclerosis to start with, there has not been increase in miscarriages. So the theoretical and the real life doesn't always line up. So this is why that risk is actually very minimal. But that's the theoretical risk, stroke and heart attack. But if you do have risks, by all means, so if you have somebody with heart disease, that's the risk.
Okay, we're going to stop because we're actually past the time that we're supposed to stop. You all had excellent questions. We're going to take a break for lunch. Lunch is out in the hallway. And if you want to venture outside and get some fresh air, please do that. And please come back at 12:45. You can come and eat your lunch in here. And I want to thank our amazing presenters this morning. It was really, we could sit here all day and talk about this, but please continue to do your education. You can go to the Miles for Migraine website. There are so many recorded videos you can all watch and answer some of your questions.
Can I add one thing in terms of the rebound? The one class of drugs that does not cause medication overuse headache is the gepants. So now we have a class of drugs where we say, go to town, use it every day, do whatever you want. You cannot cause medication overuse headache. So if somebody needs a lot of abortive and their migraine responds to gepant, because not all migraines respond to gepant. Migraine is multifactorial. Some migraine respond to serotonin, some migraine respond to gepant, some migraine respond to neither, some migraine responds to both. So if you happen to be a CGRP responders, then go to town on gepant. So why all other drugs cause medication overuse and gepants don't cause medication overuse? That's because for the first time in the history of migraine, we have an abortive that is a receptor blocker. Every other pain medication binds to a receptor and stimulates a receptor. By repeatedly stimulating a receptor, you cause changes to the receptor that starts inducing pain. gepants, for the first time in the history of migraine, sits in front of the receptor and blocks it. It's not stimulating the receptor. So if you overuse the gepants, what are you doing? You're becoming a preventive. You're becoming like all the anti-CGRP preventive, which sits there and blocks it for the whole month. So by overusing Nurtec, it becomes Nurtec preventive. By overusing Ubrelvy, it becomes Qulipta. So it doesn't matter if you overuse a G-PANT. So go to town on G-PANTs. And that's how you get over your medication overuse if you're a G-PANT respondent. Because they cannot cause medication overuse headache no matter what you do. I tell my patients, because we're med peds, right? We're seeing adults and kids. I'm seeing mom and the kids, and I said, have a stash of your G-PANTs. If you're having a bad month and she's not having, use hers. Go to your neighbors and get their G-PANT. Come, I'll give you samples. Like, I don't care. You can go to town on G-PANTs if you're a G-PANT responder.
Thanks, guys.
Ooh, that light's bright. I think we're ready to start our second session here. Can everybody please take a seat? Okay, we're going to get started. Thank you all for being here today. I hope you're enjoying this Migraine Education Day. Hope it's been informative, the presentations so far. My name is Joanna Curran, and I'm the co-founder of the nonprofit charity For the Love of Ryan. Our son Ryan began experiencing migraines at the age of 18. We took him to many different doctors, neurologists, and therapists, and psychiatrists, and they prescribed him a variety of medications and treatment plans. After 5 years of living with debilitating migraine pain with very little relief, Ryan became very depressed. He was suffering both mentally and physically. At the age of 23, Ryan ended his life as a way to stop the pain. We are very grateful for the incredible strides that have been made with new migraine medications that have come out in the past 6 years. Amavig arrived on the market 2 weeks after Ryan had passed away. And there are so many fantastic medications that are out there now. Through our migraine journey with Ryan, we felt there was a lack of awareness, understanding, resources, and support for the migraine community. For the Love of Ryan raises awareness and support for our local migraine community, all of you. We want to ensure that not only your physical needs are met, but your mental health needs as well. We offer in-person migraine support groups, education days, individual therapy, anxiety workshops, and DBT therapy. Those services are provided through our partnership with the Summit Counseling Center. Cassie Murphy is at the table in the back of the room, and hopefully you've had a chance to stop by and chat with her about our resources. For the Love of Ryan also supports children and young adults in our community with depression, anxiety, and suicidal ideation, or whatever challenges life may bring. We are here to support and advocate for you. Please visit our website, fortheloveofryan.com, to learn more about the resources available to our community, and follow us on Instagram and Facebook to learn about our upcoming events and what we're up to. Thank you, and enjoy the rest of your day.
Okay, I'd like to introduce our next speaker, and she is Dr. Jennifer Steiner, and she's a board-certified clinical health psychologist, founder of Beyond the Body Health Psychology Services, co-director of Center for Mental Health and Aging's Continuing Education Program, adjunct faculty at Emory School of Medicine, board member of the Georgia Psychology Association Board of Directors, co-chair of the Continuing Education Committee for Georgia Psychological Association, and member of the Committee of Health Psychology and Integrated Practice. Dr. Steiner is one of the first board-certified clinical health psychologists in the state of Georgia. She received her certification in 2018, and she received her PhD in clinical psychology with an emphasis in health psychology from Purdue University. Dr. Steiner has worked with over 1,200 individuals with chronic pain over 10 plus years. Dr. Steiner was previously employed as the primary pain psychologist for the Atlanta VA healthcare system for over 6 years. She also has published multiple peer-reviewed articles on the impact of chronic pain on mental health, psychological correlates of chronic pain, and psychological interventions for those with chronic pain. Dr. Steiner's research and clinical practice focus on chronic pain and interventions for chronic pain. And with that, I'd like to welcome her to the stage.
Can everybody hear me okay? Am I too loud? I want to be thoughtful about that. Okay. All right. Well, first of all, I just want to say thank you so much for having me. I am truly, truly honored to be here today. Chronic pain is an issue that is very near and dear to my heart, especially as it relates to migraines. And as you just heard, my practice focuses primarily on helping people cope with the impact of living with any type of chronic pain on their quality of life. And I think it's really important that we all recognize the fact that, yes, obviously living with migraine affects your body physiologically, right? But it can also affect a lot of different areas of your quality of life too. And it doesn't take long before it can start to feel like migraine is calling all the shots and you're no longer in control anymore. And I think that's how we kind of get to the place where it really does start to impact people's mental health and quality of life. So, per usual, I always jam too much into a talk. Are the slides advancing? Okay, cool. We're not going to talk about that. I always jam way too much into my talks. Really what I want for you all to take away from today is a better understanding of how migraine can impact mental health. I also want you to be walking away with a couple of tools under your belt to help you cope with it a little bit better, particularly the relationship between stress and migraine. I'm going to say this right away, just so that we don't get the wrong idea. Stress and anxiety do not cause migraines. Dr. Corey said that this morning. They don't cause migraines, but living with migraine can cause stress and anxiety and depression. And those things can make the migraine worse and harder to deal with. So we do have to deal with both in order to adequately manage it, okay? So that's what we're going to be talking about today. Ooh, I cannot see that. Okay, so we've talked about this a lot already today, just the idea that living with migraine really can start to affect the entire person. One of the things that I hear most from a lot of the people I work with is that they don't feel like they're driving their own ship in life anymore. They feel like they have completely lost control and the migraine is the thing calling all of the shots. And obviously, if you feel like that's what's happening to you, and a lot of times it is, right? Because those migraines can be debilitating. And some of the medications that you take to help you knock you out, make you tired. So that's, interfering with life too. And so a lot of times people feel like, I'm just at the mercy of this condition. I have no control. I don't know about you, but I don't like feeling out of control. Okay, I hate feeling out of control. And so that feeling all by itself is enough to be really unsettling to people. And people will talk about that. They'll talk about, I don't have control over my own body. I don't have control over my own life anymore. You also hear people talk a lot, and you guys know this because you live with this, right? About just the things you're not able to do as easily anymore, right? A lot of times people will tell me, well, you know, I can't get through the workday sometimes. I'm having to leave early, or I'm not able to go to my kid's soccer game because it's going to be too bright and I woke up with a migraine, right? Oftentimes the things that many, many people take for granted become really important when they're missing. And they go missing pretty easily when you're dealing with migraine or really any type of chronic illness. The last thing that I hear very commonly from people is this idea that there was maybe a you before you started experiencing migraine. I see some people nodding, right? And then there's the you now. And so a lot of times people talk about, I almost have to mourn who I was before I started having pain, I started having these other symptoms, and who I am now. And there's that sense of loss and that sense of changes in who you are as a person and how you see yourself. I think it stands to reason that when all of this is happening, that's going to affect your mental health, right? If you see yourself differently, if you're not able to engage in life the way that you want to, the way that your heart and soul desire to, that is going to have an impact on your mental health. So we have to be really thoughtful about that and recognize that this is more than just how it affects your physical body. All right. So I think we all know that it affects your quality of life. Everybody in this room is either dealing with migraine or loves somebody dealing with migraine. But I also think it's helpful to know that the research supports it, right? A lot of times certain doctors and certain scientists, and quite frankly, the people who fund drugs don't listen unless we have research behind what's going on. You all are lucky because Dr. Corey and his colleagues totally get it, but some people don't. So the research does support the idea that migraine has this horrible impact on quality of life. Specifically, if the more frequently you have migraine, the more intense those symptoms are, and the longer those migraines last, the more severe the impact on quality of life. Okay, that's kind of a no-brainer for us, but again, it's nice to have the data to support it. The other kind of common thing that I hear from a lot of people is that family and friends just don't get it. Sometimes families start to get it when they live with you and they see the impact it has on you, right? But a lot of people really don't get it. I hear from a lot of well-intentioned people, oh, it's just a headache, right? It's just a really bad headache. No, it's not just a really bad headache. And how diminishing does that feel when somebody talks to you like that's what you're experiencing? So that's a big impact. And I think we have to be thoughtful about the way that it can affect relationships. Because if you don't feel heard and understood and validated in your relationships, that relationship is going to suffer. So that's another way that quality of life can be impacted. And then I hear this a lot. For those individuals who are fortunate enough to still be working, it can really negatively affect work, right? You don't always know when those migraines are going to occur. We know that computer screens and the bright lights can be really, really triggering for some people. Stress at work can be really triggering for some people. And so the research kind of suggests that as many as 50% of people who are still working are reporting that their migraines are getting in the way of their actual performance and ability to progress in the workplace. So that's stressful too. If you feel like you can't move forward in your career, that is going to cause stress. So we see all these ways that the impact of migraine is causing the stress, not necessarily the other way around. All right. I know you guys can't see this table, so I apologize for that. But really what we're looking at here is a list, if you can see it in your handouts later, just a list of all the ways that migraine can impact quality of life, all the negative ways that migraine can impact quality of life. And what you can probably see in this slide is that the list is pretty long and it's not exhaustive. All right. It looks the same, but it's not. This is a slide that actually shows some of the top triggers for migraine. Again, it's really, really long. As some of the physicians were talking about this morning, when you live with migraine, you're living with a hypervigilant brain. Your brain is hypersensitive to things, and so lots of things can become triggers. The number one thing on this list that you probably can't see is stress. Okay, and I want to talk about why stress is probably one of the number one triggers for people. So, we kind of already covered that, so I'm going to skip it in service of time. I also want to point out before we talk about the stress piece that migraines and mental health conditions commonly co-occur together. You probably can see this slide. So this is a table looking at rates of different mental health conditions among people who have migraine. You see right up at the top, depression is at about 40 to 47% of people. That's pretty high. Anxiety is around a little bit more than 50%. These things are commonly co-occurring as a result of dealing with all of these negative impacts. We also do see that people who have had a history of trauma growing up tend to experience migraine more. Again, I think sometimes that statistic is misconstrued to mean that stress and anxiety are the kind of cause of migraine, but that's not actually true. There's just a link there, oftentimes associated with the hyperexcitability of the nervous system. Okay, so let's talk a little bit more about the relationship between stress and migraines. What do I actually mean there? So I think when we use the word stress, we're all possibly talking about different things, and I think we need to be on the same page. So I want to start right off at the bat by saying that stress is not always a negative thing. We've been talking about stress thus far in the context of dealing with migraine and all of the ways it can be really challenging, and that absolutely is stressful. But sometimes in life, even positive things can be stressful. I can tell you for certain some of the best things in my life, you know, moving into my first house and kind of getting ready for all of that, dealing with my kids when they were babies, super amazing things. I was super stressed out. Some of the most stressful times in my life were actually around the positive events. So it's not just about the stuff that's negative. It's always about the stuff that is challenging in some way. And of course, just living day to day with your migraine symptoms in and of itself is challenging and is a stressor. So I want to point out that stress does not have to be life-threatening. There's this myth out there that in order for it to be stress, it has to be life-threatening because that's what activates the fight or flight response. That's not true, okay? Anytime our brain interprets a situation as threatening in some way, shape, or form. So that could be a threat to, am I going to get through my workday? It could be a threat to, I am not the same person I was anymore. My sense of self is completely threatened by this situation. Or it could just be like, I don't know how to handle this. It's beyond my control and I don't have the coping skills to deal with it. All of that is considered a threat, and all of that can activate your body's natural stress response, okay? So it's not necessarily just one thing, and it's not necessarily one specific event. A lot of it has to do with the way that your brain makes sense of it and the appraisals that your mind gives you. When I say appraisals, I'm actually talking about thoughts. So if your mind is giving you a thought like, I don't know how I'm going to handle this, that is going to get interpreted very, very quickly by the brain as something that is threatening and stressful, and you're going to have a stress response. That's just how our bodies work. And we'll talk about that a little bit more in a minute. So really what I want you to take away from this is that when I say stress, I'm not just talking about the emotional side of things. I'm also talking about how the body physiologically responds to this concept of stress or threat. Okay. So this is, we call it the general adaptation syndrome. It's actually a really old model that's been fine-tuned a lot since then, but I think it's a really nice way to just get a basic idea of how our stress response work. So what you see there, the red line is your body's kind of regular physiological activity. So the way our bodies are designed is that when we have a stressor, it could be migraine related or not, right? It could just be like you're trying to deal with your kids and they're driving you crazy, because that happens, right? But when we have a stressful situation, there's this moment of pause in the body, and it happens really fast, and we probably don't even realize it. But there's this moment of pause where our brain has to recognize the situation as stressful. And once the brain recognizes it as like, okay, I don't know what to do, I don't know how to deal with this, the body does go through these physiological changes to help us deal with it. So you see that red line dips a little bit and then it comes back up. The reason it comes back up is because once your brain interprets the situation as stressful, all of these neurochemicals are released. Cortisol is one of them. There's also a variety of other neurochemicals that get released as part of the stress response. So you have this surge in these neurochemicals. Finally, the body gears up to deal with the stressor. And I don't know about you all, but anytime I've had this happen, there's a bunch of things that happen in the body. One of those things are the muscles tense up. Your breathing might get sped up. You may feel tightness in your chest. You may feel your heart pounding. These are the things that we typically associate with your fight or flight response, right? And then what happens is your body is gearing up to deal with the stressor. And once you've dealt with it, or when your body can't withstand that stressor anymore, it kind of comes back down and things are supposed to even out. Your body's trying to maintain homeostasis, right? Dr. Corey talked about this morning that the brain is trying so hard to maintain homeostasis. But when you have a migraine brain, when you have a hyperactive brain, it doesn't take much to throw off that homeostasis, and it doesn't take much for this stress response to be activated. Okay, so this is what's happening. You're kind of getting tipped over the edge over and over and over again all day long by things that really shouldn't necessarily tip it over the edge. Does that make sense? Okay. All right. So we talked about some of the ways that this happens. When you have that stress response in the body, not only are you having increased muscle tension, and a lot of us know from experience that when you've got increased muscle tension up in the neck and shoulders and coming up into the back of the head, sometimes that can serve as a migraine trigger. But also those neurochemicals that are released as part of the stress response actually amplify pain signals. I know it's kind of crazy to think about that, but we actually have chemicals coming back down the spinal cord that make those pain signals even stronger, if you will. And so you're already feeling crappy, you're already in pain, and guess what? Now we're just exacerbating it. It's not your fault. None of this is your fault. This is just how our bodies are designed to work. And in a system where your brain is hyperexcitable, this is happening way more often than it should. So when you kind of consider the fact that stress and worry about the migraine itself is causing this to happen over and over and over and over again, and then you throw in the fact that we live here in the United States where we have a lot of things to be stressed about every single day, some of which are not necessarily life-threatening, but threaten our productivity, threaten how we see ourselves, you're just getting activated all day long. So this is what I like to think of as the cycle of stress and migraine. You see here that it says it's a bidirectional relationship. And what I mean by that is it always, at least for people with migraine, it starts with migraine. But then once migraines are on board, stress and migraine can feed each other. So in this cycle, we've got migraines. Trying to manage the impact of that migraine can be very, very stressful for people. Then you can have an exacerbation of migraine symptoms. Well, what do we do when our migraine symptoms are really bad? For a lot of us, and I'm saying us because I also get migraines, for a lot of us, we end up in a dark room with no sound or very light sound, trying to avoid all of the things that cause us to feel worse, trying to avoid all of our triggers. And while we're trying to recover from those symptoms, we're missing out on life. And I don't know about you, but when it happens to me, I feel really guilty about the things that I'm missing out on. And I hear from a lot of my clients that they feel the same way. And so if you're feeling really guilty that you're missing out on your kid's soccer game, or you're missing out on that work project you're supposed to do, or nothing's getting done around the house, well, that's stress, right? Those are all those threats I was talking about. And once that stress is on board, it has the potential to exacerbate migraine symptoms. And so you end up in this nasty, vicious cycle. Good news is there are things we can do to stop the cycle. Obviously, there's the medication options that were talked about this morning, but there are also things we can do to help turn down our body's natural stress response as well. Okay, so let's talk about relaxation training for a minute. All right, does anybody know what relaxation training is? Sort of, kind of, maybe? Okay, so I want to point out that when we're talking about relaxation, I'm not talking about lying on the couch watching TV. That's nice. That feels really good. I'm not going to lie. I love to do that. But that's not what I'm talking about. I'm talking about doing things that physiologically slow down your body's natural stress response. Okay, you're causing a relaxation response rather than kind of the recreational, just hanging out, I'm relaxing on the couch. So that's what we're talking about here. So this is considered to be an evidence-based way of actually slowing down that stress response, helping to decrease muscle tone, helping to slow down the cascade of neurochemicals that are kind of coursing through your body when you have stress. And sometimes by doing that, that can help prevent the pain from getting even more intense. or it can help prevent a stressful situation from being a major trigger. And there's even some research to suggest that when you engage in relaxation training on the regular, you may actually be able to, over time, change that hyperactivity in the brain with some help from some other things. It's not enough all by itself. So the other kind of benefit of relaxation training is it can help to stop some of the thinking that contributes to the stress in the first place. So when you're engaging in relaxation training, you're focusing on, it can be a variety of different things, and we'll talk about those in a minute, but oftentimes it has to do with focusing on your breathing or focusing on a specific image in your mind. You're not thinking about the things that are stressing you out to begin with. And by halting that thought cycle, you can kind of halt the response to it. Okay, so there's a lot of different relaxation training techniques. One of them is called diaphragmatic breathing, okay? And this is really the first place I start with most people. Diaphragmatic breathing is kind of what it sounds like. It's breathing using the diaphragm muscle. I'm gonna step away for just a moment. Diaphragm muscle is right here, essentially. So your diaphragm muscle is under your rib cage, and it is essential for when we breathe. Basically, when we inhale, the diaphragm helps the rib cage pull down so we can expand the rib cage and fill the rib cage and the lungs with air. But a lot of times in our day-to-day life, we have to use our diaphragm, but we're not really breathing in the way that our bodies are designed to. Because life is stressful, we and most of us have ended up becoming chest breathers. All right. And let's think about it. Even when somebody tells you, oh, take a deep breath, what do? That's not using my diaphragm, that's using my chest, okay? And that's not gonna create the same effect as if you are actually breathing from your diaphragm. When you use your diaphragm to initiate your breathing, this is oversimplified, but basically it sends a message to your brain that tricks the brain into activating your natural slowing down response, the opposite response of your stress response. We call this your parasympathetic nervous system, okay? And so what we do with diaphragmatic breathing is we teach people to breathe using their diaphragm. Oftentimes we call it belly breathing because it's one of the quickest ways to start activating the opposite of the stress response and slowing some things down. So that's one way it can look. Paced breathing is another way that this can look. So paced breathing is kind of what it sounds like. You're still usually using the diaphragm, but it's timed. So you'd breathe in, ooh. You'll breathe in for a count of 3 and out for a count of 3, or you'll breathe in for a count of 4 and out for a count of 6. You're really extending the out breath and slowing down the breathing, again, as a means of kind of tricking your brain into that slowing down response. Guided imagery is another really great tool. This is what I think a lot of people traditionally think of when they think of relaxation techniques. So if you've ever done one of these meditations on an app or on some of the exercise apps that are out there right now, and they tell you to go for a walk in your mind and go sit on the beach and imagine the waves flowing, that's guided imagery, okay? You're basically going somewhere calm and relaxing in your mind, and sometimes by creating a very vivid image of these relaxing places, you can get a little bit of that slowing down effect. It's not my favorite exercise, but some people love it. Body scan is another potential relaxation exercise. Typically with the body scan, you're starting either at your toes and working your way to your head, or you're starting at your head and working your way down to your toes. And what you're doing with this is kind of thinking about each muscle group one at a time and really trying to get those muscles to release tension and relax through prompts, usually on a recording. Progressive muscle relaxation is another version of this. This is kind of a cool one. So what you're actually doing here, you're still working toe to head or head to toe, still working specific muscle groups one at a time. But what actually happens is you actually create more tension. So if I was doing my hands, I'd ball my hands up like this and count to 10 and then release. And the idea here is that if this is your normal baseline and you kind of build the tension, build the tension, build the tension, when you release, you're going to have a pendulum effect. And so it's going to go boop, and you're going to slip all the way back into like a hyper relaxed state in those muscles. This is a really good option if you're purely trying to reduce stress. I don't love this for people who have chronic muscle tension. So if you have chronic muscle tension as part of kind of how migraines present for you, I wouldn't go for this one. And then there's autogenic warming. This is kind of a cool one. For a long time, this was kind of the go-to option for people who have migraines. What this really is these are relaxation exercises designed at creating the sensation of warmth and heaviness in your extremities, so in your hands and in your feet. There was once upon a time some hypothesis that this had something to do with kind of vasodilation and drawing some of kind of the attention away from your head. I personally think it's just distraction, but it does seem to work for people, okay? So those are all some options. I want to say one more thing about this. A lot of times in pop culture these days, we hear a lot about mindfulness, right? Mindfulness-based stress reduction, mindfulness meditation, and I think people think it's the same thing as relaxation training. It's not, okay? And this is kind of nitpicky, but it's just not. Mindfulness is simply the practice of paying attention on purpose without judgment. That's it. And a lot of times it gets confused with relaxation training because many of the mindfulness exercises involve paying attention to your breathing, closing your eyes, the sense that you're slowing down. But the purpose of mindfulness is actually not necessarily to create that relaxation response. The purpose of mindfulness is just to learn how to pay attention without judging what you're experiencing, and also how to kind of train your attention back to the present moment. So I think mindfulness can still be helpful for people with migraines in that when you're having thoughts that create more stress, or where you're having anxiety-producing thoughts because you feel like you're not going to get things done, it can help you recognize that thinking and say, okay, I'm going to redirect my attention to what I'm doing right here and right now. Or it can help you recognize that thinking without getting kind of stuck on it. But it's not quite the same thing as relaxation training. Mindfulness-based stress reduction is an evidence-based strategy for managing pain, and it can be effective in migraines. There's a variety of mindfulness-based stress reduction programs through Metro Atlanta, and I think some of the organizations mentioned here today even offer that. So that's something to consider. Okay, let's take a break from listening to me talk about this, and let's actually try it. Is everybody on board with that? Okay, cool. So what I want to invite you all to do, if you feel comfortable doing so, I'm going to invite you to close your eyes just because that really helps to turn our attention inward, and we find a better effect when we're able to do so. But if you don't feel comfortable closing your eyes, I completely understand that. Just find a spot in front of you to kind of fix your gaze on. Okay. So I want you to start just by kind of getting settled into your seat. Trying to let go of all of the things that came before this today. So letting go of some of the stuff you heard about this morning, just for the time being at least. And maybe letting go about any worries or concerns you have about things you have to do for the rest of the day. And you're just going to focus on the right here and right now. And I invite you to start this by really starting to attend to the physical feeling of your breath. Noticing how your breath feels in your body. And at first, you don't need to change your breathing, so you don't need to slow it down. You don't need to speed it up. I just want you to notice that physical sensation as you breathe. And as you're breathing, some people find it's helpful to really focus their attention on the tip of their nose. So you're noticing the breath as it flows over your nostrils and then down your windpipe. And then noticing the feeling of the breath as it comes back out. Just stay with that for a few moments. And as you're continuing to breathe, if you've noticed that your mind has started to wander or pull you off to other thoughts about other things, perhaps about things you've got going on today, perhaps about physical sensations in your body, whatever, it doesn't matter. Minds wander, that's just what they do. But when it does, I want you to notice it and then just gently bring your attention back to the tip of your nose and the physical feeling of your breathing. Really letting your breath serve as an anchor or a constant resting place for your attention. And even if your mind wanders 10, 20, 100 times in the next few moments, that's okay. Just practice bringing it back to the physical feeling of your breathing every time. And then I'm going to ask you to change your breathing just a little bit. So you're going to breathe in through your nose and out through your mouth. And I invite you to think about how that feels different. Your inhales passing over your nostrils and your exhales passing over your lips. Again, using the physical sensation of your breath as your constant anchor for your attention. Now I invite you to allow the breath to get just a little bit deeper. And as you do so, I want to encourage you to place one hand over your chest and one hand over your belly. And once again, just notice your breath. So as you're breathing, now take notice of which hand is moving more, whether it's the one on your chest or the one on your belly. And if you're like most people, you may be noticing that it's the one on your chest. And if you're noticing that it's the one on your belly, good for you. You're in the right direction, but there's no judgment here. So I'm going to invite everybody now to really focus on their belly as they breathe. So with your next breath in, I want you to visualize the breath flowing down your windpipe and then expanding into your belly, filling your belly with air like a big balloon. And as you exhale, your belly naturally sinks back toward your spine. As you inhale, the belly expands, filling up with air. And as you exhale, it just naturally relaxes. Good. I want everybody to stay with that, really focusing on allowing their diaphragm or their belly to do most of the work for the next few breaths. All right, beautiful work, everybody. And we're going to add one more layer to this. So in a moment, we're going to slow the breath down even more, still doing that deep belly breathing. I'm going to count to 3, and I want you to inhale slowly for the count of 3, and then you're going to exhale slowly for the next count of 3. So here we go. Breathing in, 2, 3, and exhale. 2, 3. Breathing in, 2, 3, and exhale. 2, 3. Still breathing into the belly as you inhale. 2, 3, and exhale. 2, 3. Inhale. 2, 3, and exhale. 2, 3. And I'm going to invite you to keep breathing on that same tempo in your own mind for the next 30 seconds to a minute, and I'll keep track of the time. And you're just using your breath as that anchor for your attention. And as always, if your mind starts to wander off or get distracted by other things, when that happens, just bring your attention back to this slow 3-count belly breathing. And at this point in time, you can allow your arms to drop back to whatever position is comfortable for you. Maybe bring some energy back into your body by wiggling your toes or fingers. And when you're ready, you can open your eyes. Okay, so that is an example of what I usually might do for a foundational relaxation exercise with people. That's like where we start. And the reality is that's a combination of multiple techniques that I had talked about before. So in that, we did a little bit of awareness of breath, that the mindfulness piece was where we were noticing where our mind was kind of getting distracted by other things and using the breath as an anchor to help us train our attention to come back. And then we did the diaphragmatic breathing piece with paying attention to our belly breathing. And then at the very end, when I added in the counting, that's paced breathing. So the reality is you can combine some of these techniques, and I often do. in order to get maximum effect. So I want you to think about how your body felt while you were doing that. Hopefully it felt good, but sometimes the first time it doesn't, and that's okay. Let's see. Uh-oh. For some reason, my clicker's not working anymore. There we go. Oops. It advanced a little bit too much. So the other part of working on stress is actually about paying attention to your thinking. And I know some of you all might be thinking, how in the world is paying attention to my thinking about my stress actually going to help with anything? Well, the good news is it actually does. So I don't know about you guys, but my mind often looks an awful lot like that person on the right. There's just a lot of mind clutter going on. There's worry, there's stress, there's all kinds of things that are happening in my mind. And that's not always super helpful, right? So the good news is we can slow it down. So when you pay attention to your thinking, you can recognize its impact on you. And I need you all to get on board with me for this next statement just for a second. So the way that I have been trained as a psychologist, what your mind gives you in terms of your thoughts about a situation directly impacts your mood. Okay, it's thought and then the impact on mood, as well as the impact on your physiology, as well as the impact on your behavior. Your thoughts direct all of those other things. Now, the good news is we can change our thoughts so that the outcomes are different, but really it's the thoughts that are driving the show. And so when your thought is creating anxiety or your thought is creating stress, everything that follows is because of that thought, okay? I also want to point out that even when the thought that your brain is giving you is true, right? If what your brain is telling you is like, oh my gosh, my pain is so bad, today is going to be an awful day, and that feels really true because it may be, doesn't mean it's always helpful. All right? It's not about whether or not the thought is true or understandable. Most of the time it is, but it doesn't mean it's going to help you, because if it's causing more stress or if it's causing more anxiety, it's going to potentially lead you astray. I don't know if you all can see this, but basically it's kind of like a little roadmap of what happens. So in this particular example, what happens is the person wakes up in pain, wakes up with a horrible migraine, something that I bet a lot of us can relate to. And the first thought that may go through your head or that goes through this person's head is, oh my God, I'm in so much pain. Today is going to be an absolutely horrible day. I'm going to get nothing done. I don't know why I even tried to schedule something. It's never going to get better. Kind of this cascade of thoughts. Well, the natural outflow of those thoughts is this sense of threat, right? That threat that like nothing's ever going to get better, nothing is ever going to get done. And so that activates our stress response. Of course, that's going to activate the stress response and cause some anxiety, and for some people, depression. And then we're going to potentially have that cascade of chemicals going through the body that makes all of those physiological side effects of stress happen, and potentially the pain could get worse. And you may end up staying in bed all day as a result of that. There's no judgment and there's no shame in that. It's the natural outflow of that thinking. Now, if instead of having that thought process, what went through your head was, okay, I'm recognizing this pain. I've got a plan. I've got that sumatriptan spray in the bathroom, and I'm going to take it and give myself 30 minutes, and I'm going to get this under control. That's going to feel so different. Or if you say, okay, I've got a plan, I'm gonna call my doctor, I'm gonna go in for an infusion. I've got a way to handle this. Feels so different than, oh my God, how am I going to get through this day? So you can see how our thoughts can really play a major role. All right, so I want to be honest with you, I'm cramming like several sessions of therapy into 20 seconds. So these are some shortcuts here. But when you do notice that your thinking is generating more stress or more anxiety about any given situation, it doesn't have to be pain related. I want you to start asking yourself, is this thought helping me or hurting me? Not is it true, not is it valid. Your thoughts are often valid. Not always, sometimes they're not based in reality, but a lot of times when we're talking about pain thoughts, they are. Is it helping me? Okay? And if you can say, no, it's not helping me because it's making my stress and anxiety worse, well, then you can ask yourself some of the other questions on this slide. This is in your handouts, by the way, or if you guys have received handouts. If not, we can send them to you. So you can ask yourself, are there other pieces of this situation that I'm not taking into account? Or are there alternative ways for me to think about this? Those extra pieces of information in the example I gave may have been some of those abortive medications that are hiding out in the bathroom, right? So getting into the habit of asking yourself, is there another way to think about this? The other one I really like is asking yourself, what would you say to a loved one or a child or a best friend that was in this situation? A lot of times we're a lot better at coming up with kind advice to give others than we are for ourselves. And when we think about what we would say to others and then turn it back on ourselves, it can be really helpful. All right, these are some helpful coping thoughts. I told you I'm cramming in a lot of sessions of therapy into a short period of time. So these are some of my go-to helpful thoughts that I encourage people to use, kind of positive self-talk, positive mantras. I can handle this. I know what I have to do. I just have to get through this 1 minute at a time. Or I can handle this. I just have to get through this particular migraine. Rather than thinking about all of the other migraines that are likely to happen in the future, you're just trying to get through that one. You're just trying to get through that hour, okay? Or I'm gonna focus on what I can do and what I can control rather than the parts of my life that I feel are out of control. A lot of times for my clients, when they're feeling good, I'll have them make a list of all the things that they are still able to do and all of the things that are within their control so that when they're feeling bad, they can look at it on their phone, and that can just help to kind of calm down some of that anxious and stress-related thinking. Um, and this is one of my favorites. There may not be a cure for migraine, but there are definitely some things I can do to manage it, or I can still find a way to live my life. All of these things can help to kind of slow down how anxious and stressed out you feel in the moment. They're not going to necessarily cause the migraine to go away, but they might help prevent the stress response from making it even more intense. Okay? All right. So really briefly, I want to talk about this concept of acceptance. I think acceptance gets a really bad rap. A lot of times in our culture, we think about acceptance as giving in. We think about saying, I give up. We think that's what acceptance is, and it's not. This is probably my favorite thing to talk about, so I'm going to do it fast. Acceptance is really saying, I didn't ask for this situation. I would have never chosen this situation, but it is what it is. It is what it is, and now I'm going to do the best I can to live the best life possible with it. I'm going to stop putting all of my energy into trying to make it go away in ways that aren't working. You can still put your energy into the ways that are working. You absolutely should. You should do all of the things that definitely work for you. But stop doing the things that clearly aren't working. Because I know a lot of times you're so desperate to make that pain go away that sometimes we keep doing things that we learned a long time ago don't actually work. It's like Dr. Corey said, stop looking for the foods that you think are triggering your migraine. If there was a food trigger, you would have found it by now. Put that energy towards something else. Put that energy toward living the best life you possibly can. So that's what acceptance is. It's saying, I'm going to control what I can, and it is what it is with the rest. Okay, so some additional resources. I do think that sometimes it can be really helpful to find a therapist, not just to work on relaxation training, but to also just kind of work on better dealing with the depression and anxiety that can sometimes come along with living with these types of conditions. I would encourage you, though, to find a therapist, if possible, that has experience applying these types of strategies for chronic pain. So CBT is a wonderful, wonderful treatment option. CBT for chronic pain is its own thing. So if you can find somebody who does that, that's great. Acceptance and commitment therapy is another option. I've listed some of the directories that might be helpful in finding a therapist. Also, Summit is an amazing resource there in the back. Check them out. I do this work, although I get booked up. So I hope that these resources will be helpful. These are some additional resources. So there's tons of information on the American Migraine Foundation website, as well as the Miles for Migraine website and the For the Love of Ryan. I've listed these apps here. These are all relaxation-based apps. Calm is a great one. I love it, but it's also a subscription and you have to pay for it, so it's not always a good fit for everybody. The Virtual Hope Box is one that's free, and the nice thing about the Virtual Hope Box is it includes relaxation exercises as well as some of the kind of thought-based coping strategies. And then the two listed below, Migraine Monitor and Juva, are specifically for migraine. These are two self-help books. The one on the left is an acceptance and commitment therapy for chronic pain book. Walks through a lot of the techniques that might be used in therapy if you were using this approach, but it's meant to do kind of as a self-guided method. And the one on the right is the CBT equivalent to that. And that's it. Do I have time for questions? No? Okay. That's my website. That's my QR code. There's a lot of resources on my blog if you want to check it out.
Excellent, right? I hope you got something from that. I know I did. If we have time after the breakout sessions, maybe Dr. Steiner can take a few questions. We're going to be sending you all these handouts, so don't feel like you have to jot everything down right now because that'll just add more stress. Okay, so what we're going to do next is a couple of things. First of all, if you are on Zoom, we are actually going to say goodbye to you all now. You are going to go into your own breakout rooms in just a moment, and you are going to have your own follow-up with your moderators on Zoom. And then we are going to have you guys closed out on Zoom. So thank you all for being here. If you were joining us virtually today, it was great to answer some of your questions, and we'll say goodbye. And so if you're in this room, we're going to break out into five groups. We're going to do, you want to do the, oh yeah, Kathy, come up. Okay, come up. Let me just finish this and then Kathy's going to speak to us. We're going to break out into, we're going to count off by fives and then we're going to chat for 20 minutes. The questions are going to go up on the screen in just a few minutes. And then we're going to come back and if you can share, one person can share from each group. That would be fantastic. And then we're going to do some amazing door prizes at the end. So don't leave because we've got a lot of door prizes. And so while you're sitting there, if everybody can just jot their name down on either one of the 3x5 cards or a yellow piece of paper, we're going to come by and collect those in a few minutes. But I'd like Kathy to come and speak to you now.
Hi, first of all, what a wonderful presenters we've had today. Do y'all agree? Dr. Steiner, that was a lot of great information. I echo everything that you said. A lot of times in the mental health field, we talk about how our physical health, our mental health can impact our physical health. But as you all know, our physical health can also impact our mental well-being. And thank you for all that you shared today. I am Kathy Murphy, Director of Community Outreach at Summit Counseling Center. And in my position, I get to work a lot with organizations in our community, bringing partnerships together so that we can serve the mental health and mental well-being needs of our community. And one of those relationships is our relationship with For the Love of Ryan. I'm very thankful for our relationship with Craig and Joanna Curran at For the Love of Ryan and Dr. Corey and his team at Southeast Center for Headaches. We partnered together. The For the Love of Ryan raises funds to be able to support the work that we do at the summit so that we can provide services to you free of charge. And I think there's some information on your table or in your packet about that, but please come back and visit us at the table. Those resources are 5 free individual sessions of therapy. We also have a support group for the migraine community that will be starting back up again in January. And then we have a DBT program that uses CBT skills that the For the Love of Ryan provides free of charge for you. So those classes meet once a week. We have both an adult and an adolescent program. So stop by the table to see us after the event is over. 2 of our wonderful therapists are here today. Dr. Hogue and Teresa Anthony are here. You can talk to them and learn more about how you can sign up for the resources that we have available for you. Thank you.